Halo. Hi, good evening, everybody.
Good evening, sir.
Hi, good evening. Who's that?
Nikhil.
Ah, good to see that you're on the group. I just left you a message. Okay, we're getting there. People are logging in fast. Can you see my screen?
Yes.
Can you see my screen?
Yes.
Yes, sir.
Good, good, good. And the voice is clear?
Yes, sir.
Yes.
Okay, that's good.
How are you, Prof?
I'm all right, thanks. I'm all right. Just a bit tired, but I'm all right. There's lots to do actually now. From tomorrow onwards, you got a lecture every. Managed to get all these guys to give time. You know, everybody's busy, so particularly with the COVID thing happening. But happy that people are all contributing. I sent a message to all the Indian senior surgeons as well. Didn't get much response from them about teaching. Okay. What's the time? Are we ready? No, still 2 minutes. Okay. I can see a lot of new names on this group. I don't know if I know everybody.
Yes, even I am seeing
A lot of new names on the group. Huh? Good, good, good. I do believe that a lot of anesthetists are going to log on as well today. So I've been told. So no pressure on me at all. Okay, so the time is 5 o'clock. Let's start today's session. Everybody can hear me loud and clear?
Yes.
Just give me a quick yes. Okay, fantastic. So today's session is actually in three
Recording.
parts. Oh, yes. So what a good, who said that?
Bhushan.
Well done, Bhushan. Well done, well done, well done. Now, where am I? Where is the recording? Hang on. Where is the recording?
Sorry to interrupt.
No. Very important. Most important thing. Something. What has happened? Hang on. Just a second. Where is my settings of this? Stop live screen record. Let me just 1 minute. Let me start recording first. Record on this computer. Can you see the recording sign?
Yes. Yes, sir.
Yes, sir.
Good. Well done, Bhushan. Good you remembered. Otherwise, two hours later is no good.
Yeah.
Okay, where is the show? Okay, good. All right. Good. You guys can see the recording sign. I can't see it here. I don't know
Yes,
where it's
you
gone,
can see.
but it's recording,
Yes,
no?
sir.
Oh, okay.
Yes,
All right. Good. Fantastic. So today we're going to talk about thoracic anesthesia, and then I will talk about ERAS because I think it's all related. So you need to know all the principles, and everything is designed for the exam. I've tried to highlight important points for you. This is not an anesthetist talking about this topic, so you got to understand it's from a surgeon to surgeons. I've tried to keep it very simple. I don't want to make it very complex for you. So I'm going to start off first with a video which I recorded about 10 years ago, an interview with Dr. Yatin Mehta and Dr. Sangeeta. Both of them have been my anesthetists at Medanta and probably one of the finest anesthetists I have worked with anywhere in the world, to be honest. Both of them are super, super good at what they do, and particularly when it comes to thoracic anesthesia. So let me start with that video. It's a 10-minute and 42 seconds video. So let's go through that. And then I will do my talk, and I'll talk through every aspect of thoracic anesthesia. Try to cover all the everything that is we use in the theaters, and then after that, if you still have enough time, I will cover ERAS. I will cover all the guidelines on ERAS. So whatever I'm going to say is directly from the ESTS ERS guidelines on enhanced recovery after surgery. So it is worth listening to that, specific answers for specific questions. Okay. So let me start off with Dr. Yatin Mehta and Dr. Sangeeta. It's not a very complex thing. It was in theater just as we were about to induce a case for a VATS lobectomy. So listen to them, and then we'll all be quiet during that period, and then I will start the actual lecture after that video.
So can't hear audio.
Really?
Yes, yes. Audio is not.
Yeah.
No audio, sir.
Absolutely zero audio.
Yes, sir.
Yes.
Yes. Okay. One minute. Let me just. Okay. Just 1 second. Sorry about that. I will have to come out of sharing, and I will play it on another mode. Okay. Sorry about that. It's just I thought I had embedded it into the PowerPoint. Can you hear the audio now?
Not yet.
No
No,
audio.
sir.
Can you?
Not yet, sir.
We can hear you speaking, but no more audio.
Not the audio. 1 minute. Okay, I have to share my screen with you actually. So 1 minute. Hang on. Again, I'm sorry about that. Can you hear the audio now?
No.
Great.
Can you hear the audio now? Somebody give me a thumbs
Not
up.
yet.
No, sir.
No audio.
So let's skip. Okay, so that's fine. That's fine. It's all right. Don't worry. Let's just skip this, and I will get to the lecture straight away. Sorry about that. It's okay. I don't know what's the problem, but I'm not going to sit and solve it just now. Okay. All right. Now everybody switch off your microphone. Yeah, come on. Hello. Can you hear me?
Yes, sir.
Yeah, good.
Yes, sir.
Everybody else, please switch off your microphone.
Yes. On the YouTube, it is audible on YouTube.
Yeah, but it's okay. Never mind. I've skipped that video. I'll show it to you again later on. Let's get on to the lecture. Okay, can you switch off your microphone, please, Mr. Whoever this is? Thank you. I cannot start if you don't switch off your microphone.
Dr. Hemant, Dr. Vinay Kulkarni, these are the two.
Okay, so let's start with the talk. I'm sorry that first video didn't play. So there are many challenges when you do thoracic anesthesia. Okay, it's not a simple anesthesia. It's a very complex anesthesia. And the main challenge is that as a surgeon, very often when you are doing endobronchial surgery or when you're doing rigid bronchoscopy and things like that, you're actually sharing the airway with the anesthetist. And that's a real problem. And that is something you really need to understand. That's why you really have to have very good coordination with your anesthetist. The second issue when you do thoracic anesthesia is you're actually going on one lung ventilation. You're completely changing the ventilation and the perfusion profile of the lungs, and you have to be ready to deal with this change in the ventilation perfusion profile. Many thoracic surgeons are elderly patients with many comorbidities, and these are issues that don't do well with anesthesia, and that's something that we have to keep in mind. And of course, the need for post-operative ICU stay or ventilation. You have to very early identify which are the patients who are going to need ICU stay, who are the patients who are going to need ventilatory care. Not all of my patients go to ICU. In fact, 99% of my patients do not go to ICU. I like to put them in a post-op recovery room, and within 4 hours, I send them back to the ward. But there is 1 to 2% of patients who specifically we identify even pre-operatively that these are the guys who are going to need ICU. And I'll tell you about how to identify which are the patients who will need ICU or ventilation. So really, thoracic anesthesia and thoracic surgery is seriously a team game because we are both sharing the same space and we really need to understand each other's requirement. So the team that consists of doing thoracic anesthesia starts with the pulmonologist, because these are the guys who do the the pulmonary assessment of the patient. Then of course it is the anesthetist who does the fitness for anesthesia for these patients. Then comes into the picture the surgeon, and last but not the least, the ICU physician. And really, to have a successful outcome for a patient, you need to be able to do a good sort of interaction between all 4 of these together to ensure that the patient safely comes through a very complex surgery and safely comes through onto the other side. So I personally give this example of a pulmonologist, of an anesthetist and a surgeon in thoracic environment. We are like 2 bananas in a single peel, so almost like twins, or you can call us as 2 peas in a pod. And if one of us doesn't understand the need of the other, or if the other doesn't understand the need of the first, then there is going to be complete chaos. And the problem of that chaos, the price of that chaos is paid for by the patient. And at the end of the day, no matter what you do, you need to make sure that the patient does not suffer. And that is the key reason why a thoracic surgeon and a thoracic anesthetist have to almost marry each other and understand the requirements of one and another. So let's start with the very, very basics. Let's look at the anatomy of the chest with relation to anesthetic considerations. Okay, so we need to understand that the trachea is about 10 to 12 centimeters in length. The diameter is about 1.5 to 2 centimeters. It has got about 15 to 20 C-shaped rings, and the carina lies at T5. Okay, the carina lies at T5. These are all important points to remember whenever we are talking about anesthetizing a patient, because depending upon these measurements, you will actually decide what is the size of the tube, what is the length of the tube, what is the kind of blocker that you need to use. So it's very, very, very important that the anatomy of an individual patient is analyzed very critically on the CT scan. So even before you start inducing the patient, you should actually, as an anesthetist and as a surgeon, talk to each other about what is happening on the CT scan to the carina, to the trachea and the carina. Is there obstruction? Is there deviation and things like that? So these have to be discussed in the pre-anesthetic clinic with the anesthetist. The right main bronchus is 2.5 centimeters long, and it is shorter than the left main, and it is more vertical than the left main. Again, this orientation is pretty important when you're trying to put in a double lumen tube into the right side. You need to understand what is the length of the right main bronchus and what is the orientation of the right main bronchus. As you know, the left main bronchus is 5 centimeters and it is longer than the right main bronchus, and the left main is more horizontal. It lies more horizontally, as I'll show you in some pictures. So when you choose a right-sided tube or you choose a left-sided tube, and when you intubate the patient either into the right or the left side, you must know these figures and this orientation, because it will help you move your arms in the correct way to direct the tube into the left side or to direct the tube into the right side. If you do not understand that the left main bronchus is more horizontal, you will push straight forwards and not realize that you've actually got to tilt the tube into the left side and go more horizontally. So it is very, very important to understand the anatomy of these two things. The other important thing that you have to understand is that the right upper lobe bronchus can fire out around 2.5 centimeters from the carina. Now, this is a rather inconsistent anatomy. Very often there are variations at where the right upper lobe bronchus comes out. And preoperatively, the anesthetist must see the CT scan in detail, particularly when they're going to be putting in a right-sided tube, because a very early bifurcation of the right upper lobe needs to be understood preoperatively. And 3D CT reconstruction is extremely helpful in trying to identify where is the right upper lobe bronchus exactly, because your tube has to lie exactly opposite the right main bronchus. The Murphy's eye on the tube, I'll talk about that in a minute. The Murphy's eye on the tube should be exactly opposite the right upper lobe bronchus. Hence, it is very important to understand in every patient on the basis of CT or 3D reconstruction, where exactly is the right upper lobe bronchus and what is the orientation. And as I said, it could get occluded by a right-sided double lumen tube. So it is very important to know these anatomical variations pre-operative, not on table. And hence, doing a bronchoscopy or a virtual bronchoscopy or a 3D reconstruction of the CT really makes it very safe for the patient. And I would strongly recommend all anesthetists to do this as a matter of routine. The right lung is larger, is heavier, and has 3 lobes. That is very basic things. And more importantly, it takes 55% of cardiac output. So when you're doing a right pneumonectomy, the considerations are different as opposed to doing a left pneumonectomy. The left lung we know is smaller, and it takes about 45% of cardiac output. Now, these are just standard facts which I put out there because I want you to keep them in mind when we start talking about thoracic anesthesia. So this is the orientation of the lungs. We have seen this from my previous lectures. You get into the airway and then you come up to the bronchus, you come to the right side, and then you've got the takeoff of the right main bronchus, usually at around 3 o'clock on your bronchoscopy when you're looking from the head end. And then you continue downwards into the bronchus intermedius. And we did talk about the various branches of the middle lobe. This is the middle lobe. This is the apical of the lower lobe, and this is the common basal. Similarly, on the left side, you have a takeoff of the upper lobe, and then you have the apico-posterior and the apical of the and the anterior of the upper lobe, and then you've got the lingula. So this is an anatomy. I'm not going to go through this again because I have taken a very detailed class with you guys. But just to show you, there are 19 bronchopulmonary segments, 5 above the horizontal fissure, 5 below, Similarly, on the left side, there are 5 above and 5 below. Please switch off your phones, yaar, please. You know, I love your children, but please switch off your phone, yaar, guys. I don't know how everybody's coming in and the phone is still on. Okay, now we are 100 and we are locked. Can you everybody make sure that your phone does not accidentally come on, because I'm wearing earpods and any disturbance rings very loudly in my ears. So please, for my sake, do not switch your microphones back on. Okay. Okay. Thank you. So where were we? So let me just go back 1 minute. I lose my chain of thoughts. You see, that's the problem. Okay. So we were talking about the bifurcation of the right and the left. It's important to remember 5 bronchopulmonary segments above the fissure, 5 below, 5 on the left side and 4 below on the left side. And we spoke about the bronchopulmonary segments, 3 in the apical upper lobe, 2 in the middle lobe, and 5 in the lower lobe on the right side. And the same orientation on the left, but 3 in the upper lobe on the left, 2 in the lingula, and only 4 in the lower lobe. The medial is missing. Okay, it is kind of important to know this anatomy so that you can actually, when you're doing intubations and things, you should know what exactly you're trying to block. And again, the way to identify which is the upper lobe and the lower lobe is to look for the trachealis muscle. I'm not going to go through all of this. I'm just flashing these images for you to recollect what I did in my last lecture. So there's the bronchus intermedius, 3 structures: middle lobe, common basal, and apical of the lower lobe. This is the left upper lobe, and then this is the left lower lobe. Look for the trachealis muscle. It tells you which is the lower lobe, always a good sign. And then you get into the upper lobe and it shows you upper lobe proper and the lingula. And when you get into the lower lobe, you get apical segment of the lower lobe on the left side. 7 is missing. As we mentioned, 7 is actually medial. And we still got the anterior, lateral, and posterior branches on the left side. That's basic bronchoscopy. Again, I went very fast over it because I've done a very detailed 2-hour lecture on it last time. Okay, so whenever you're working up a patient for anesthesia, what are the routine blood tests that you want to do? Of course, it starts with a full blood count. You do need to know what is the hemoglobin of the patient, is he anemic, and any other things that you can pick up on a full blood count. Urea electrolytes are pretty important because you want to know the renal function of the patient. You want to know any hyponatremia, hypokalemia, hyperkalemia, stuff like that. Liver functions are also quite an important baseline characteristics because a lot of drugs that are used during the anesthesia can be hepatotoxic, and we need to make sure that there is no derangement of the liver function. A clotting profile is extremely important for a surgical patient because you need to make sure that there is no clotting abnormalities, particularly when you're trying to intubate. The last thing you want is to call hemoptysis in the patient. A routine chest x-ray and an ECG is mandatory for looking at the chest and for the cardiac profile. That's very, very basic stuff. We have spoken about spirometry. I did a whole talk on spirometry, on pulmonary function tests. So I won't go into details of this, but a static spirometry with the FEV1, FVC, FEV1, FVC ratio, and a DLCO, diffusion capacity of the lung. Also a good idea for thoracic surgery patients to have a baseline ABG. Always you need to know a baseline ABG so that post-operatively when you do an ABG, you have something to compare to. There's no point in doing an ABG afterwards and not knowing whether has the ABG changed or not changed because of the anesthesia. Hence, always preoperatively, it's a good idea to have a baseline ABG. We do the assessment of fitness. We have been through the whole lecture, 2-hour lecture on fitness for thoracic surgery. So we do a stair climbing test. We do a 6-minute walk test, and we do a stress walking test. All of this can be done. And if for patients who are doing poorly on these tests, we have to bring them up to, we have to analyze their cardiopulmonary exercise capacity by doing a CPAX, a VO2 max of more than 15 is a good outcome for surgery, and anybody less than 10 is very bad outcome for surgery. So these are the sort of baselines that we look at. Again, I'm not going into details because I've done a 2-hour lecture on this. So I'm assuming that everybody knows the ESTS, ERS guidelines for fitness for thoracic surgery. We do need to see these FEV1, FVC, FEV1 ratio, not just by themselves, but you got to repeat them after bronchodilator therapy and as a baseline, just as a routine baseline. Now, this is not part of ESTS guidelines, but it is there in the BTS guidelines. Anybody more than FEV1 of 1.5 liters is okay for lobectomy, and anybody more than 2 is okay for pneumonectomies. But when we did the lecture on fitness for surgery, we did say that absolute numbers should not be used. It is actually the percentage predicted that we need to look at. So anybody more than an FEV1% predicted of more than 80%, according to the ESTS guidelines, is fit for surgery. ERS says, the ACCP says more than 60% predicted is fit for surgery. So these are the numbers that you need to remember when you are starting to sit in a pre-anesthetic clinic. Again, you need to know, this got repeated, preoperative evaluation is important. Patient is usually a high risk, or at least your antenna should stand up. If there is a problem with FPC, FEV1, FPC, the ratio, there's a problem with the RV-TLC ratio, or the diffusion capacity is low, or there is a PaCO2 more than 45 millimeters of mercury. Again, these are all standard numbers. I'm not saying these are rigid. We have been through the guidelines and we know each number in more detail. Okay, so you've got to identify whether the patient has got a restrictive disease depending upon the FEV1, FVC absolute numbers and the ratio. And then again, you've got to identify whether the patient has got obstructive lung disease depending upon a reduced FEV1, stable FVC, hence a reduced FEV1 FVC ratio. Again, I'm not stressing too much on this because we have discussed this in detail in the past. So let's look at the anesthetic issues. Let's look at perioperative issues. FRC is an important component of anesthesia. Good oxygenation of FRC is important because when you oxygenate, FRC is functional residual capacity. If you oxygenate, then you can actually give a longer apnea time to the patient. Again, another important factor which anesthetists look at is called as a closing capacity of the lung. This is the capacity at which the smaller alveoli collapse. And it's quite important to understand that moment in an awake patient, the FRC is always more than the closing capacity. Hence, the lungs remain open. But the moment the patient goes under anesthesia and you go on single lung ventilation, the functional residual capacity becomes almost, the closing capacity becomes almost equal to functional residual capacity. And when that happens, then there is a scope for collapse of the lung, atelectasis, infection, etc. So the anesthetist has to work hard by giving PEEP to ensure that the smaller alveoli do not collapse and do not cause consolidation. So that's just a basic understanding of how the physiology is. We must always look at predicted postoperative FEV1 and predicted postoperative DLCO. Again, we have been through the ESTS ERS guidelines. We know that these are very important numbers, and these are the numbers which actually predict good outcomes or bad outcomes in the postoperative period. The one thing to remember is that no matter what you do, the moment the patient has surgery, the FEV1 and FVC reduces 65%, reduces by 65% on the first postoperative day. Hence, physiotherapy and analgesia are extremely important. The reduction is because of pain, because of poor effort tolerance by the patient, reduced coughing effort by the patient. So the anesthetist has to preoperatively plan what he needs to do postoperatively. Analgesia is a very, very important part of the whole process of planning for thoracic surgery. And you have to discuss with the patient the concept of either whether he's going to receive an extrapleural catheter or a paravertebral, or he's going to receive a patient control analgesia. So all of this has to be discussed preoperatively with the patient. And again, the physiotherapy domains have to be well documented and well analyzed and practiced. Anybody with a predicted postoperative FEV1 of less than 40% has more risk of getting respiratory complications. That is the bottom line. And more importantly, anybody with a less than 30% predicted postoperative FEV1 has a high risk of having ventilation. So when you calculate the predicted postoperative FEV1, you will be able to book an ICU bed straight away. So anybody who has got a PP FEV1 of less than 40, my suggestion is you must book an ICU bed, and you must discuss with the intensive care physician that it is likely that this patient may come to the ICU ventilated. Most of our patients are actually extubated on table. We are very, very adamant about that. And we'll discuss that later about why we should extubate patients on table. So it's very important to understand when preoperatively you must book an ICU bed. So anybody with compromised cardiac function, anybody with compromised respiratory function, anybody with compromised renal function who might need a dialysis in the postoperative periods, these are the 2 or 3 main risks where you must book an ICU bed. Another indication where we usually book an ICU bed is when we are doing a post-transplant patient, particularly who are on immunosuppression and things like that. So we always make sure that the ICU bed is booked before the operation, not after the operation, because you may not get an ICU bed if you start looking for a bed after you have completed the operation. Okay. Now, the other thing to understand is the functional residual capacity changes with position. Lateral supine and prone positions actually push the diaphragm up. And we all know that functional residual capacity is after the patient has the capacity left in the lung after the patient has taken a deep inspiration and expiration. So it's important. The FRC is the key thing that keeps the alveoli open. Okay, the closing capacity and the FRC is important. The moment the diaphragm gets pushed up, the lung gets squashed against the chest wall, the FRC goes down. So, and also the moment you get, you have anesthesia, the tone of the diaphragm and the effort of the intercostal muscles goes down. So this is why it is very important that you have to make sure that the patient is well oxygenated and that the closing capacity does not reach the same as FRC. Otherwise, you will get atelectasis, air trapping, and very often during the operation, we will actually maintain a PEEP to keep that alveoli open. Okay, all right. VQ mismatch with anesthesia. The operated lung is perfused but not ventilated. The side that you're operating upon is perfused but not ventilated. The other lung is more ventilated than perfused because you're really pushing all that capacity into the opposite side lung. So there is a scope for mismatch, and the best way to correct any ventilatory perfusion mismatch is to increase oxygenation. Hence, FiO2 is pushed up to 100% and to clear the CO2. And so that these are the 2 basic principles of how anesthesia should work to maintain the patient's oxygenation, increase the oxygenation and clear the CO2. And again, I said the same point that it's very important to make sure that you maintain a PEEP to allow the alveoli to stay patent. Okay. Just a quick feedback. Did this make sense what I just said? These are very basic principles I'm
Yes,
trying to
sir.
explain to surgeons.
Yes,
Did
sir.
it make sense? Again,
Yes,
I'm
sir.
not going into details of PFTs because we have done a very, very detailed question of PFT. Okay, because this is a very long topic and I want to cover everything possible. So far so good. The philosophy is clear. Oxygenate and clear CO2. That is the philosophy of anesthesia. Okay.
Yes, sir.
So
Yes, sir.
preoperative
Yes.
optimization includes getting the patients to stop smoking. Very important. Even a 24-hour stoppage of smoking actually clears carbon monoxide from the blood. There is enough evidence to show that even 24 hours, if the patient can stop smoking, his postoperative outcome is good. So the risks go down even with just as little as 24 hours. Of course, if you can stop him for 6 weeks, that is great. But it is important to talk to the patient in the pre-anesthetic clinic about stopping smoking. If he's got reversible airway disease, if he needs a course of steroids, go ahead and give steroids. But at the time of the operation, I don't want a high dose of steroids on board. I want steroids reduced to at least to less than 10 milligrams per day. It is mandatory. I don't like high doses steroids. I want it to be down as low as possible. The one steroid which I don't mind is the inhaler steroids. Okay, so Becotide and things like that are okay, but oral steroids should be reduced. It's very important for me. You must optimize the patient. Nebulization is good for the patient. Improve the exercise capacity. If you can give him an exercise pathway to follow along with your physiotherapist, that is great. And he must receive preoperative respiratory rehabilitation by learning things like yoga and deep breathing exercises. And this protocol works really well and is actually mandatory for lung volume reduction surgery. I never ever operate on a patient until and unless he has had at least 6 weeks of preoperative rehabilitation, as we call it, prehabilitation. It's called as prehabilitation, which means that you must undergo 6 weeks. You must get as good as you get, okay, before you come onto my operative table, because anesthesia and surgery is a deadly combination for thoracic diseases, and you will take a big hit to your body and you will go backwards. So I want you as good as you are before we start doing these operations. That is why all of this preoperative optimization is mandatory. Of course, you cannot do it in every patient, particularly when you're dealing with lung cancer and things like that. But a lot of our work may be non-cancerous, and that is elective surgery. We must insist on these sort of optimizations. It is mandatory. And this happens in the pre-anesthetic clinic, okay? An anesthetist is important to monitor the patient, and the parameters that the anesthetist looks at is respiration, oxygenation, ventilation, and the cardiovascular function. These are the 4 parameters around which all monitoring of the patient works. So let's look at what are the basic monitorings and what are the advanced monitorings that are needed in a thoracic surgery patient. So we always start with basic airway monitoring, and one of the things is end-tidal CO2 and measuring of airway pressure. These are basic numbers which will actually give you some input into the performance of the patient. We look for airway gas and pulse oximetry. We want to make sure that circulation is okay. So we look for ECG, blood pressure, pulse oximetry. Now the blood pressure can be non-invasive blood pressure, but better than that is if you put in an arterial line, you'll get a continuous trace. And particularly when you're doing complex thoracic surgery cases, I would like to see a non-invasive, I would like to see a arterial line tracing on the screen. And that gives me more comfort when I'm seeing this patient being managed. Nerve stimulation is needed by the anesthetist, particularly when they are relaxing the muscles. They need to know what is the level of relaxation, is the patient coming out of relaxation, etc. And of course, the temperature is important because we are exposing the patient to low temperature. The operating theater's temperatures are suboptimal, and the body's cavities are open to the outside. So the patient has an inherent tendency to lose temperature. So it is important that the patient is monitored, and also quite important to make sure that the patient has a warming blanket on himself or herself. Somebody is raising a hand. Is it something urgent or can it wait? Abhishek, anything urgent? Okay, so let's carry on now and talk about additional monitoring. So these are basic monitorings. The additional monitorings that are mandatory are arterial line, Again, arterial line is actually not a must with all thoracic surgery patients. In London, we may or may not do arterial lines, particularly when you're doing smaller thoracic cases, less than 1 hour. We don't really want to put in an arterial line. It's only when you're doing a lobectomy or a pneumonectomy or things like that, that we go down the route of an arterial line. A central venous line, again, is used by a lot of anesthetists. In the UK, we do not use central venous line as a routine, even if we are doing a lobectomy or a sleeve. It's only when we are going to be doing surgeries on compromised patients who have cardiac compromise or whom we expect to have problems. Those are the ones where we will put in a central line. In the UK, really one arterial line, one large Venflon cannula, and a double lumen tube is the way we manage almost all straightforward thoracic surgery cases, including lobectomies. There is something called as a bispectral index, which is a machine with a probe kept on the forehead, which monitors the brain waves, and it gives you an idea of the depth of anesthesia. I'll show you about that in a minute. And then, of course, if you've got a patient who is compromised from a cardiac point of view, then you put in a transesophageal monitoring and keep an active check on the patient's cardiac functions. There is something called as a tiered system of monitoring. This is 3 levels, level 1, 2, and 3, depending upon how sick is the patient. You decide whether he's a tier 1 or a tier 2 or a tier 3 system of monitoring. But the first and foremost important thing about monitoring is that a failure to check your basic equipment before you start the case is actually responsible for almost 22% of critical incidents. So it doesn't matter whether you've got arterial line or whether you've got central line and all that. The basic thing before you start the case is that you have to do an equipment check. You have to make sure that the whole anesthetic trolley is working. You have to make sure that the cylinders are full, the connections are correct, the settings have already been preset. 22% of incidents happen because you did not do a complete check of your equipment before you started the anesthesia. Once the patient is under, and if you've got a problem with your equipment, that is too late. And usually the price for your mistake is paid for by the patient. So it is very, very, very important. The first system of monitoring is to make sure that your equipment is checked properly and you do not have any problems with equipment. And if there are problems, don't compromise. Change the equipment. Either get a new trolley in or do whatever it takes. In fact, if the equipment is not right, you should postpone the case. I don't care. I want a live patient coming into theater and I want a live patient going out of theater. And certainly not going to the ICU because the anesthetist forgot about something on the equipment monitoring. So I am very happy to cancel or postpone the case until and unless the equipment is right. Okay, this is our moral, legal, and ethical responsibility towards the patient. So the tier 1 level of monitoring is called as essential monitoring in all patients. Saturation and end tidal CO2. Fiber optic bronchoscopy is now included in this after a double lumen intubation. More and more people are now banking on ensuring that your position is correct with a bronchoscopy. And so it has now entered a level 1 tier as if almost an essential for all thoracic surgeries. And the others are quite straightforward, nothing different, blood pressure and oximeter and things like that, which I said. A tier 2 includes monitoring of the lungs, split level lung monitoring, including lung compliance and measuring the pulmonary artery pressures if there is lobectomy or larger lung resections. And then there is also inclusion of a central line. So these are the two things that are added for a little more complex case. And then, of course, if you're dealing with somebody with very poor cardiac function or very poor respiratory function, then do all of the rest, include a PA catheter or include a transesophageal echocardiography. So this is the way you decide. You pre-operatively in the pre-anesthetic assessment, you decide whether this guy is tier 1, tier 2, or tier 3. And moment you decide that, you have to make sure that everything is available as is placed out on the chart. So this is the way the anesthetists actually work out for these patients. Capnography is a very good tool for assessing what is happening in the tube, and also a good tool for seeing how good is your isolation of the patient, because we said two factors are important. One is how much is the oxygenation of the patient, and number 2 is how much CO2 is being washed out. This is the most important thing in the patient. Oxygenate, wash out CO2. Oxygenate, wash out CO2. Hence, an understanding of end tidal CO2 is quite important. This is a capnography graph that is displayed on a continuous basis with every breath. And usually if something goes wrong, it is the end tidal CO2 which gives you an early inkling whether the patient is doing well or not under anesthesia. So looking at the saturation of the patient and looking at the end tidal CO2, you can very early decide while you are monitoring the patient that something is going wrong, and you can tell the surgeon, stop your surgery, let me sort out whatever is wrong with this patient. So it is quite important to understand that. This is a standard anesthetic monitor which should be available to you as well. This is not a screen which should be available only to the anesthetist. I will not operate if a second screen is not in front of me, because it is my responsibility to look at the blood pressure. It is my responsibility to look at the heart. Many a times when I'm operating on the lung and I'm trying to retract, I will put pressure on the left ventricle or the right ventricle because I'm retracting across that area. And if I don't tell the anesthetist that watch out for pressure, I am retracting, the anesthetist will think something is wrong with the heart, and he will start pumping in adrenaline and it's atropine and God knows what. So you as a surgeon, it is your responsibility to look at the monitor, and more importantly, if there are any change in the cardiac events because of your movement, you have to pre-warn the anesthetist. Another important thing that people do when they're operating on thoracic surgery is put in swabs when they're trying to pack an area off, and they forget to tell the anesthetist that there is actually a swab on the heart. And that is the worst mistake you can make, because the anesthetist doesn't know why the blood pressure suddenly becomes 60. And so if you are talking to each other, you're telling each other what you're going to do, then very quickly these problems will be solved. And if you've got a swab mop on the heart and the anesthetist knows about it, he will be able to tolerate a 60 blood pressure for a little period of time to let you do what you're doing. And so it is important to talk to each other and look at the monitor. Always have 2 monitors in theater. Never ever go into theater with just a single monitor. One monitor must be facing the anesthetist, but one monitor should be in your eye line. You must be watching the heart rate, the blood pressure, and also the saturation of the patient. Very important. If an anesthetist has got falling saturations, your principle is to stop the operation. Do not fiddle around and stress the anesthetist. Because at the end of the day, between your fight with the anesthetist, the patient is the one who will go hypoxic and has a risk of having hypoxic cerebral injury. So absolutely mandatory that if the saturation is dropping, you stop what you're doing and ask the anesthetist to reinflate the lung. Stop being on single lung ventilation. Tell the anesthetist, please blow up the lung, get the oxygenation back up, and then you can wait for 2-3 minutes, joke with your colleagues, and then come back. Once the oxygenation has reached 100%, you can restart all over again. So this monitoring is extremely important, not just for the anesthetist, but also for the surgeon, because this is a dual responsibility. It's not just the anesthetist's responsibility to watch these graphs and these charts. So that is why it is very, very, very important to look at all these factors. This is a device which is used to measure the bispectral index or the depth of anesthesia, and you get some sort of, you get these graphs on the surface which tells you where exactly you are with the level of anesthesia. Do you really need to give more? This is a very important concept the concept of understanding the depth of anesthesia, because it has been shown in thoracic surgery and even in other surgeries that very often these patients are actually aware of what you're talking, or they may be aware of what you're doing, or they may be aware of a sensation of pull or push. And this, after the surgery is over and after all the event is over, they may actually recollect some of these events. And so it is very important to make sure that your patient is actually at a deep level of anesthesia and not hovering around the medium or superficial level. So it is important. It's a holistic approach to the management of the patient. Cardiovascular function can be managed with a simple arterial line, but of course, if the patient is compromised, you can put in a pulmonary artery catheter, a Swan-Ganz, which will tell you what is happening in the pulmonary pressures. It will tell you about pulmonary hypertension. It'll give you an idea of the filling pressure. It'll help you to assess cardiac performance. And so these are good numbers to have in front of you. And you can also do a venous oxygen sampling to know for adequacy of cardiac output. So it's quite important tool which you must have in your setup. I'm not saying every patient needs a PA catheter, but 1 in 100 may need, or 1 in 200 may need. And your anesthetist should be efficient at floating the balloon catheter. And not just your anesthetist, I think even the surgeon should know how to float a balloon catheter, because in the ICU, when you look after these sick patients, sometimes you need to be able to measure the cardiac output. So it's quite important that we look at the whole parameter of monitoring rather than one. So the bottom line is monitors are there, all numbers are great, but they are just adjuncts. Okay, they are just adjuncts. All these numbers make no sense, because if you do not have a careful observation by an anesthetist, these numbers will have no meaning whatsoever. So it is very, very, very important that monitoring is used for managing the patient, but nothing can take away the experience of the anesthetist and careful observation. Because what happens with experience is you spot the trouble early and you warn the surgeon early. So both of you take corrective measures. If you start warning the surgeon when the saturation is dropped to 20% and the patient is starting to arrest, that is too late. So really a good anesthetist is one who will tell you before the event happens that something is not going right. And this is the beauty of my interaction with my anesthetist. I promise you, working with Sangeeta, working with Yatin, Mehta, they are A1 anesthetists for the simple reason that they will tell you even before things start to go wrong, they will start to warn you. Are you pushing on the heart? Is something wrong? Is there too much traction? Stuff like that. They will tell you, and very quickly you will realize. And so that way, many lives are saved because of excellent communication between the anesthetist and the surgeon. Okay, so this is the basics of monitoring. So far, so good. Is it clear?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Now let's get into the semantics of anesthesia. Let's look at the various devices that are available to you. How do we do all these complex procedures? So let's look at one lung ventilation. Okay, so one lung ventilation in a very simple and basic term is separation of the two lungs. Each lung functions independently, and there are physiological changes which are managed by the anesthetist. And the moment you go on one lung ventilation, there is a risk of hypoxemia. Okay, because obviously one lung is collapsed, one lung is ventilated, you have less alveolar surface area, the ventilation perfusion ratio has changed. So there is always a risk of hypoxemia whenever you're doing one lung ventilation. The philosophy of one lung ventilation is to prevent cross and contamination. That's one philosophy. There are many philosophies. I'll talk about it. So many a times we do one lung ventilation when we are worried about infection on one side, and we do not want the infection to come to the other side. So it's not just in theater. We're talking about ICU here as well. So philosophy, one could be to prevent cross contamination. One philosophy could be to enable ventilation of each lung separately so that you can have different ventilator settings. So, for example, in a single lung transplant, you don't want to put the same pressure on the transplanted lung as it might be on the normal lung. So you want a differential lung ventilation. So a one lung isolation will help you with differential ventilation of each lung. Sometimes the airway may be damaged on the right side and you want to bypass it, because if you blow into the right side, you will cause pneumothorax and surgical emphysema. So you push your tube to the left side and you bypass the damaged section of the airway. Sometimes you want to actually lavage each lung independently in things like alveolar proteinosis. When you want to wash out a lung of the extra protein secretions, then you can independently wash out only the right lung or only the left lung, depending upon whatever is the pathology. So let us look at the indications where we do these things. So massive hemoptysis, we know that if it's a unilateral lesion, patient is suddenly bled. The one thing these patients die of, and I've said this before, is that the blood travels to the normal side and they don't die of bleeding or volume loss. They die of suffocation. They die of drowning. And so a unilateral lesion, you can very quickly put a double lumen tube and isolate the other side, or put a single lumen tube onto the other side and block off the block off the affected side. Selected lung lavage, which I told you, alveolar proteinosis, is one of the techniques used in the ICU for one lung ventilation. Sometimes you've got copious infected secretions with risk of soiling on the normal lung, and hence you isolate that normal lung, or you isolate the infected lung and ventilate the normal lung. Unilateral parenchymal injuries following trauma, unilateral aspirations with lower lobe collapse, consolidations, unilateral pulmonary contusions, pneumonias, or to bypass a tracheobronchial tear, as I told you earlier. Unilateral pulmonary edema, particularly when you're dealing with transplant cases, single lung transplants, people with bronchopleural fistulas on one side, you want to actually protect the normal lung, or unilateral bronchospasm in certain conditions. This is a basic philosophy of why we do one lung ventilation. What are the contraindications to one lung ventilation is difficult intubation. If the patient has got C-spine injuries, or if he's got a narrow trachea or any other pathology which will make a single lumen difficult to pass, and so it will also make a double lumen difficult to pass. Hence, this is a contraindication for one lung ventilation. But you do have an option. You can pass a single lumen tube and pass a blocker through it to achieve one lung ventilation. But it is a contraindication for a double lumen tube. Obstruction of ipsilateral bronchus, of course, you cannot go across it with a double lumen tube, and that might be a problem. Or in a crash intubation, where the patient is suddenly collapsed and crashed, the last thing you want to do is go fiddling around with a double lumen tube. Okay, so in that situation, you just want to resuscitate the patient and you put in a single lumen tube, get the oxygenation going, and then do whatever else you need to do to get the isolation. And of course, unilateral bronchospasm in patients. So what are the types of double lumen, what are the types of devices available for you for achieving one lung ventilation? You have double lumen tube, which we all know about. You have bronchial blockers. You have selective endobronchial intubation, where you move the single lumen tube to either one side or the other. And last but not the least, you have certain other devices which are locally available, which we will talk about a bit later when we talk about blockers. So this is a double lumen tube going into one side, and the tracheal lumen is ventilating the other side. This is a blocker going into one side, or selective lung intervention, selective bronchial intubation, where a single lumen tube is pushed to one side or the other. So let's look at double lumen tubes. I promise you, this is 100% an exam question. 100% you will be handed, at least some of you will be handed a double lumen tube and asked to talk about it. So please listen carefully to what I'm going to say. So what are the basic safety features of a double lumen tube? Some of the features are the same as a single lumen tube, but there are some additional features of a double lumen tube. The first and foremost is they are all standard sizes, so that all connectors can fit onto a double lumen tube, similar to a single lumen tube. So 15 mm connectors will fit on most double lumen tubes. They are all made up of low allergen materials, so they can be PVC or latex-free material, okay? The other thing is they're usually transparent. The newer ones are all transparent because you need to see either vomit or blood coming through this double lumen tube to make sure that you start taking action early. If it is a completely not transparent tube, you may not see the vomit going down into the lung and you'll end up with aspiration pneumonitis. So the current group of double lumen tubes are all transparent so that you can see through them to identify any of these. All of them have markings which actually give you an idea of how deep within the airway is your tube. So the depth can be measured with the, and it can tell you whether you're in the right or the left or at the carina, okay? They all have a pressure cuff, which is high volume, low pressure. You need a low pressure cuff for the simple reason that if you've got a high pressure cuff, you can cause pressure necrosis. Hence, they usually have high volume, low pressure cuff. It's the endobronchial part that will have a low volume, low pressure cuff. I'll talk about that in a minute. But the main tracheal cuff will be high volume, low pressure cuff because you do not want to exert too much pressure on the bronchial mucosa and cause ischemic necrosis. There is always a pilot cuff, which gives you a connection to the system, which will help you to gauge what is the cuff pressure of that tube. Most of them, in fact, all of them will have round atraumatic edges. They also have Murphy's eye to protect against occlusion and to allow selective ventilation, particularly of the right upper lobe. They will all have radio opaque lines so that you can actually see the chest tube in a chest X-ray. These are the routine features that are there for single lumen and double lumen tubes. The double lumen tube per se has few more additional features than a single lumen tube. One is that the endobronchial element of a double lumen tube, there are two elements. There is an endobronchial element and there is a tracheal element, two tubes fused into one. One stops at the trachea, one goes into the bronchus. The endobronchial element is always colored blue. And the reason it is colored blue is so that you don't make a mistake of clamping the wrong cuff, okay, the wrong tube, because sometimes you might have to clamp the tracheal, sometimes you might have to clamp the bronchial when you're trying to achieve one-sided isolation. So the blue color tells you that this is a endobronchial tube. So if it is a left-sided tube, the blue element has gone into the left side and the white element is in the trachea. If it is a right-sided tube, the blue element has gone into the right side and the white element is in the trachea. So these colors are there to help you identify which one to clamp. The area which is closest to the anesthetist is made of silicone ventilator connections, okay? So clamping the tube will not actually damage the tissue, will not damage the tube itself. You should not get crush injury to the tube. So they are actually made of soft silicone ventilator connections so that you can clamp it safely and not have any damage with your on your tube. The particular ones which go into the endobronchial element have small volume cuffs because you don't want to, the bronchi are smaller in size and they are more at risk of pressure necrosis. So you don't want to cause that. Hence the endobronchial elements usually have small volume cuffs, low pressure cuffs. Okay. On the right side, particularly, it's very important that the balloon that inflates can actually obstruct the right upper lobe. So you have an eccentric balloon for right side to prevent obstruction. And don't worry, I'll show you a picture of all of this in a minute. So this is your standard one that is used these days, called as the Mallinckrodt's double lumen tube. You can see a blue element here and you can see a white element here. So blue is always endobronchial, the white is always tracheal. And then you've got these outside cuffs to tell you how much is the pressure. So this will give you a pressure gauge of what is happening in these cuffs, in these balloons. And you can see that this is a smaller balloon, this is a larger balloon. So this is high volume, low pressure. This is low volume, low pressure. Okay, so this is the difference between the various parts of an endobronchial tube. And this is the left-sided endobronchial tube. As I told you, the balloon of the right side as compared to the left side is different. Can you see that? So this balloon is specially designed to allow the to prevent the occlusion of the right upper lobe with as compared to the left. So it's very important to understand the difference between the right and the left double lumen tube. And then they also have this thing called as the Murphy eye, and the correct placement of an endobronchial tube is that the Murphy's eye should lie opposite the right upper lobe bronchus. And that way you will make sure that you're actually ventilating the right upper lobe bronchus. Again, see the same thing. So these diameters of the bronchial tube are smaller, endobronchial area is smaller. This is a larger diameter. This is the French size. The outside diameter is the French size. And usually when we say we are using a this French tube, it is actually the outer diameter that we are measuring, not the inner diameter. Okay, this is an outside diameter that helps you understand, that helps you decide which tube goes into which patient. Okay, again, I told you about the blue part. This is the blue part. This is specifically designed for the endobronchial element of the double lumen tube. Anything that is white is actually tracheal. What is blue is endobronchial. There are newer advances are available nowadays. So we have what is called as a visual laryngoscope. So even before you start putting in a tube, you know, previously we used to use the laryngoscope and lift up and put our eye to the mouth and try to see the cords and then put in the tube. Two problems with this. One is the vision is not so good sometimes. And number two, you're getting your eye really close to somebody's mouth. And particularly in these days and day and age of COVID infection, the last thing you want is his saliva spurting into your face. So one thing is important, anesthetists should wear eye protection whenever they're doing any case. They should be wearing masks, they should be wearing gowns and caps. It is important. Do not try to do these things without adequate PPE, as we call it. Please make sure that you protect yourself. So these visualized laryngoscopes actually help you to see the cords better and help you to stay away from the patient's mouth and intubate the cords. And then once you've gone in there, this is how you can see, look, the anesthetist's head is here rather than here. Most of the anesthetists, many a times, if in the old days, we used to have the anesthetist looking down here. But now you don't need to do that. This visualization puts you far away from the patient and reduces the risk of cross-infection for the anesthetist. And then the double lumen tube themselves now have a camera attached to it. So there is this camera probe right at the tip. It comes inculcated within the double lumen tube. And then the double lumen tube is connected to this monitoring device. So very clearly, as the tube goes in, you can actually see the bronchial anatomy. And out here, very clearly, you can see the carina. And more importantly, you can see the tube going to the left side. So the right side is completely free. The left side is occupied by the endobronchial element. So you know that you have actually got a good left-sided intubation. So this device, the Viva side device, helps you to selectively isolate one side or the other under vision rather than doing bronchoscopy afterward. So you're actually essentially doing a bronchoscopy while you're intubating the patient. And also you leave this monitor connected during the case. So many a times tubes move during the operation, or they move when you're turning the patient lateral. So this device will actually give you a view intraoperatively. As the operation is continuing, you will actually get a live view. And when you want to re-intubate or push the tube forwards or pull the tube back, this device will help you to do it without the need for pushing in a bronchoscope. So this is a very nice new tool. In BARTS, they use it as a routine, and I'm quite happy to see them use this device. It does add value to thoracic surgery. So this is the view that you get with the Viva site. Then you've got these connectors. These are very important part of the of the thing. The one I told you, the silicone thing is here, and these can be clamped very easily without worrying about it. The more important thing is this cap they have on the top. This is important. So any connector that you use, you should try and use one with a separate cap and at the top, so that you can put in a bronchoscope through it. This is a one-way valve. And when the bronchoscope goes through it, you get a seal of that area. And so you don't get loss of the positive pressure of ventilation. So the anesthetist can happily ventilate through here and continue ventilating the patient even while you're doing bronchoscopy. And they can also do check bronchoscopies intermittently through these caps. So these are very, very good connectors to be used in double lumen tube. And we strongly advise that you should not use direct connectors. You should use connectors with caps, which allow a bronchoscope to get into the airway. There are some older types of double lumen tubes. I'm mentioning them for academic purpose, but actually they are still used in a lot of parts of the world. Robert Shaw's DLT is something that was used in the earlier era. Again, blue for the endobronchial element and red for the tracheal element. These are very stiff, and these are not made of non-allergic materials. So some people can have some allergies to these tubes, and they are a little more stiff than the current tubes. And so they were a little more difficult to actually pass. But people who have done thoracic anesthesia for years will tell you that they were pretty comfortable for use, and they have used this for many years. There is something called as a Carlin's double lumen tube. The difference in a Carlin's double lumen tube is at the bottom here. Can you see that? There is actually a carinal hook here. This carinal hook goes and fits itself on the carina. And when it fits itself on the carina, you cannot have downward displacement of that double lumen tube. That was the advantage. It's an old type of tube. Some people still use it. This hook allows you to fix the double lumen tube and the ventilation. There is no occlusion of the upper lobe by mistake. So it continues to ventilate at a certain distance from the upper lobe. So the next question that a lot of people ask is, what are the lengths or what are the guides for using a double lumen tube? This is a very good chart. I have got this from an anesthetic paper. And as I said, the French gauge is the outer diameter gauge. So you start off with 41 French, which is the largest one. And then you can go all the way down to 26 French, which is the smallest one available. Again, you can see you have to preoperatively measure tracheal diameter. And if depending upon whatever is the diameter of the trachea, you decide what is the size of the endotracheal tube that you would use. A patient's height is a very good indicator. And so you can use a height range, 5.5 to 4.6 is 35 to 37. A taller person than that, you can go 37 to 39 or 39 to 41. Usually males will be in this area, 39 to 41. Females usually lie between the 35 to 37 area. In children, the smallest one available is 26. Which is not available as a right-sided double lumen tube, only available as a left side, 26 and 28. And that will work for a 8-year-old child. So the smallest one that you can use is up to 8 years old, 35 for 13 and 14, and 32 for 12 years old. Anybody less than 8 years, you have other options available to you. One is to put in a bronchial blocker. Number two is to do selective lung ventilation, which means you move your tube to the other side rather than the side you want to operate. And the third is you continue with 2-lung ventilation, but use CO2 insufflation to push the lung away. But of course, not a great idea when you're doing lung surgery. It's okay when you're doing mediastinal surgery and you want the lung just to be out of the way, then you can use CO2. But otherwise, you actually want either a bronchial blocker or you want a selective lung ventilation to isolate the lung so that you can get in and do your surgery. The youngest person in whom I have personally done VATS, I think is about 1 year, if I'm not mistaken. And all pediatric age groups we've done, and we've achieved 1 lung ventilation in almost all of them. But that is thanks to the efficiency of my anesthetist rather than the efficiency of the surgeon. So I have personally worked with excellent anesthetists who have always given me no cause for complaint. This is the correlation of the internal diameter versus the external diameter. So you got to just look at these. This is internal diameter in millimeters, and there is a formula which you use, which helps to calculate internal to external diameter. And we don't need to know that. You just need to know standard sizes that are available for at least surgeons. Whenever you place a double lumen tube, there are two ways to place the double lumen tube. One is a blind technique where you don't see, you just place it with experience. And the second one is a endoscopic technique where you actually endoscopically guide the double lumen tube into the desired side. So the blind technique, what you do is you intubate the patient following the natural curves of the airway and rotate it into the side that you want to rotate. Of course, if you're using a left-sided tube, it's naturally curved to the left. If you're using a right-sided tube, it's naturally curved to the right. In the old days, they used to intubate and then get both the balloons dilated and then ventilate each lumen first, and then sequentially clamp the two lumens. So start with the tracheal and then clamp the bronchial, and they listen to the chest for us. They auscultate the chest to check for ventilation. So I have worked with anesthetists who were fantastic at this, but nowadays almost everybody has got so used to using bronchoscopy, and also a lot of guidelines are now started talking about use of bronchoscopy in terms of safety for a patient. But I promise you, I had a fantastic anesthetist who used to take less than 2 minutes to push in a tube into the correct side and then say, go on, Dr. Khan, I am happy I've auscultated. But in this day and age, that is not acceptable. Of course, if you're passing a right-sided tube, it is much more difficult because you have to make sure that the Murphy's eye is opposite the right upper lobe. So when you auscultate, you have to auscultate the right upper lobe as well to make sure that you are not blocking the right upper lobe by mistake. But most people now actually have gone into a bronchoscopic guided double lumen tube placement. In this, you intubate the patient, you inflate both the balloons, you ventilate both the lumens, and then you put in a bronchoscope into the tracheal lumen. It is really the tracheal lumen that you want to put in, because looking through the tracheal lumen, you can actually see the endobronchial element going into the right side or the left side. So that is more important. So that tells you that it has gone in the correct side. So you adjust the DLT according to the position of that balloon at the carina. So you move it forward or move it back. But on the right side, particularly, you must go endobronchially into the lumen with the bronchoscope to see that the right upper lobe is actually ventilating. So you turn your bronchoscope through the Murphy's eye and try to look into that area to make sure that the upper lobe is ventilating. So this is a picture which shows you, this is the left-sided tube. Your bronchoscope is actually in the tracheal lumen. So through the tracheal lumen, you can see the left side going off to the left, and you can see the carina. So your relation to the carina is quite important. If your balloon is lying at the carina, it's highly unlikely that it's gone beyond. The left is actually a 5 centimeter long left main bronchus. So highly unlikely, if your balloon is at the carina, that you will be blocking the left upper lobe. The same thing you've got to see on the right side. You have to selectively move your ventilation, your thing into the endobronchial area on the right side to see the right upper lobe. So here is the tracheal lumen. You've gone in to see the carina, and then you go into the endobronchial lumen, and very important to see the right upper lobe and the bronchus intermedius. So this way, under vision, you make sure that they are correctly placed. But like I told you, now we have VV sight, and VV sight actually gives you a good indication of what is happening. All right. So the blind side is slightly slower to achieve good position. In fact, I think it's the other way around. I think people who were very experienced in the old days were pretty good at putting in double lumen tubes, but younger people will struggle. But you may still require bronchoscopy to troubleshoot when you've lost the isolation. But bronchoscopy is more accurate, fast, and definitely the problem is it needs a whole setup. You need an intubation bronchoscope. This is not your normal 4.2 centimeter bronchoscope that can go in. You really have to use the small 2.6 centimeter bronchoscope, and they are very delicate, and the anesthetists have to handle it with great care. If they are handled by the younger people, they aggressively move the device up and down, right and left, and end up usually damaging the fiber optics of the bronchoscope. So it's an expensive tool, and not everybody has access to an intubation bronchoscope. How do you make sure that the lung is correctly, the double lumen tube is correctly placed? One is, of course, the ventilated lung feels reasonably compliant. You have to listen to that. You have to listen around the top to make sure there are no air leaks present. If you look into the transparent part of the tube, you will actually see the gas, the moisture appear and disappear with each ventilation. And of course, flexible, in spite of doing all this, your bronchoscopy sometimes can pick up malposition almost up to 78%. So 38 to 78% is what the papers say. Capnography is a good tool to identify proper side ventilation. So see here in the capnography, if you have clamped the tube, the capnography graph goes flat, and if you clamp the other side, the untitled tube will come back up. So this measures very clearly whether you have ventilated or not. This balloon is down. Can you see this? This balloon is up, and here the balloon is down. So when the balloon is down, the end-tidal CO2 comes up. When the balloon is up, the end-tidal CO2 goes flat. So that's another technique to make sure that you are in the correct area. Of course, other methods are a chest X-ray, comparison of capnography, I told you. And then, of course, you can ask the surgeon, because the surgeon is actually going to put in a VATS camera on the side of the surgery. And many, many times after you have put in your double lumen tube, when you turn the patient lateral, the tube may shift, and you may lose your single lung ventilation. So very often the surgeon, the moment he makes his incision and goes in with his camera or by open surgery, he will tell you, sorry, the lung is blowing into my face. So then they will start fiddling around with the bronchoscope and try to readjust the double lumen tube. So don't forget these things. What about the fiber optic bronchoscope? I mentioned about that, what goes into what. From 5.6 doesn't fit into any of these. 4.9, okay for the bigger sizes, but not so good for the smaller sizes. Most of the intubation bronchoscopes are 2.6 to 3.6. So it depends on what is the type of surgery that you're doing and what type of bronchoscope you have in your theater. Okay. Double lumen tubes are not without complications. They're not easy things to shove into the airway. Failure of intubation is a definite no-no. It can happen with patients. You can fail to isolate the lung because you have not placed it correctly. You can cause tracheal injuries. These are known to happen. Bronchial injuries are known to happen, particularly if you've shoved it too hard or you didn't take the stellate out at the final manipulation. And of course, airway edema. If you push too hard against the vocal cords, you can get airway edemas. Esophageal intubation these are now for just intubation, the complications of intubation. So you can have esophageal intubation. You can have somebody clamping on the tube, on the tube with their teeth, or you can have phlegm which will block the tube. You can have dislodgement of the tube above the glottis. You can have cuff rupture or pressure loss because of the cuff rupture. Intubation trauma, perforations are known to happen with intubations. And last but not the least, mucosal ulceration or necrosis in prolonged intubation. So these are things that are not to be taken lightly and should be done only by experienced people. Okay. Everything okay so far?
Yes, sir.
Yes.
Yes, sir.
Is it making sense? Am I going too fast, or shall I
No,
just
sir.
continue
No,
at
sir.
this pace?
Okay.
Because a lot of it is pictorial, so you can understand these things quite easily. I don't want to go really slow, otherwise you'll get bored. There's a lot to cover. Okay. So now let's look at bronchial blockers. So we've understood double lumen tube. I promise you, you will get a double lumen tube in the exam. Whether you're doing DNB, FRCS, MCH, I don't care. It's a favorite question, and the favorite question is whether it's a right-sided double lumen tube or a left-sided double lumen tube. So please learn to identify. I have clearly told you what are the factors which make it a right side and what makes it a left side. Bronchial blockers. Again, what are the indications? More or less the same as putting in a double lumen tube. You want to avoid contamination of diseased lung, infections, massive pulmonary hemorrhages, unilateral lavages, for distribution of ventilation, bronchopulmonary fistula, in giant unilateral lung cyst where you're losing volume on one side. The ventilator is not able to ventilate because all of the tidal volume is going out through the bulla or through the cyst. You want to actually isolate that lung and then ventilate the normal lung. Or in airway trauma, severe hypoxemia due to unilateral lung disease, you want to make sure that the normal lung is adequately ventilated. In cases where you need to do nasal intubation, you actually prefer to isolate using a double lumen tube will not go through the nose. In a small patient, a double lumen tube may not fit into the airway. In cases of difficult intubation, you might put in a single lumen and then pass in a bronchial blocker through the single lumen. In patients with tracheostomy, again, double lumen tube is very difficult to pass through a tracheostomy. The space is not adequate, so very rarely, in fact, almost never will you do a double lumen tube intubation in a patient with tracheostomy. You'll put in a single lumen and then pass in a bronchial blocker. In cases of subglottic stenosis, where a smaller tube needs to go in patients with very thick or excessive secretions, where there's a risk of blocking both the tubes, you will put in a bronchial blocker. These are the types of surgeries which we have done under bronchial blockade: pneumonectomy, lobectomy, esophageal resections, transplant, aneurysm surgeries, and thoracic spine surgeries. So this is quite a standard thing to give in the exams. Why do you use bronchial blockers? It's good when you cannot do double lumen tube or you don't have the experience to do double lumen tube. So existing endobronchial tube is already there. You don't need to change it to a double lumen tube. You push in a bronchial blocker. It's good in difficult airways, cervical spine injuries, because you don't want to manipulate the neck too much. Major airway trauma in distorted tracheobronchial anatomy, really important, because a double lumen tube to pass through somebody who's got a deviated trachea or a deviated upper lobe or things like that because of tumor, it's almost impossible to pass a double lumen tube. And in those situations, you can actually manipulate a bronchial blocker across this distortion. A double lumen tube will never pass across a distorted trachea. Then, of course, when you need lobe-specific blockade, either because of hemorrhage, air leak, or infection, it's safer than a double lumen tube in a traumatic airway injury, because double lumen tube may actually exacerbate the trauma while you're trying to pass it through or push it through. And so it's better to pass in a single lumen, stay as far away from the injury as possible, and then gently pass a bronchial blocker across into the opposite side, because they are much more thinner. The bronchial blockers are very thin, and so they can pass across more safely. And technically, they are simple, more simpler than double lumen tube intubation. There are limitations with bronchial blockers. The problem with bronchial blockers is you cannot suction beyond it, because once you have blocked it, really the lumen of that bronchial blocker is so thin that you cannot really suck the lung distal to it. So very often you're stuck with an inflated lung with trapped air and trapped secretions, and it becomes difficult for the surgeon, particularly when you're trying to do VATS. The other problem is a smaller diameter ET tube will not take the bronchial blockers. There are some blockers which will not pass through smaller double lumen tubes. And the other thing is, because it's a very narrow diameter, the collapse of the desired lung will be very slow. So you really need to take time to make sure that the bronchial blockers are you need to make sure that you pass the bronchial blocker and give adequate time for the lung to collapse, because it does take more time than a double lumen tube. And the other thing is they can get easily dislodged. They are very fine catheters, and they, little manipulation on the surgical side, pulling and pushing the bronchus while you're trying to staple can easily dislodge. And the other important thing is that when they get dislodged, they might come into your staple line. That is the most dangerous thing to happen. So you got to be very, very careful when a bronchial blocker has been passed. Because you need to make sure that it doesn't dislodge and come into your staple line. That would be a disaster, actually. There's a risk of perforation of a bronchus. If you push it too deep, you might get into across the bronchus into the parenchyma. The upper lobe is particularly difficult to block with a bronchial blocker because the takeoff is at a very awkward angle. And the bronchial blocker cannot turn and enter the upper lobe. So it's very difficult to selectively block the upper lobe. On the right side, you can very happily pass it into the bronchus intermedius. That's not a problem. But the right upper lobe is very difficult to block with a bronchial blocker. The mainstem surgery becomes difficult when the bronchus is blocked. Hence, you got to pull back the bronchial blocker when you're doing sleeve resections and things like that. If a bronchial blocker is in your way, you cannot do those sort of things. And bronchoscopy of the blocked lung is not possible, which means that you cannot suck, so nothing can come out, but nothing can go in as well through a bronchial blocker. Hence, you cannot see what is happening distal to the bronchial blocker. So these are things that you have to sort of understand when you're doing bronchial blockade. The various types of bronchial blockers that are available are univent bronchial blockers, Arndt's endobronchial blocker, a Cohen flexitip endobronchial blocker, and then we have got the local blockers which you use when you don't have any of these fancy things. So things like a Fogarty's catheter or things like a Foley's catheter. So these are all that come in the last category. Okay, so let me just take you through these things and show you what is happening. Somebody's phone has come back on. Please switch off. Okay, all right. So this is a univent endobronchial blocker. This is how it actually looks. This is the tube. This is a single lumen tube, but the beauty of it is there's a second lumen, a third lumen through which the bronchial blocker can pass. Check this out, the bronchial blocker passes through that. It comes as one unit. And so you intubate as normal, like a normal thing, and then you push this tube across into the side that you want to get into, either the right or the left, by manipulating the top. And then this cuff is again measured by this thing. So you can actually create a pressure to tell you exactly where the to tell you how much air is there in the bronchial blocker. Okay, so this is the way it works. You have to usually do this under a guidance of a flexible bronchoscopy. So a flexible bronchoscopy going through the tube will actually guide you when you are manipulating the tube. After you have manipulated, you need to make sure the position of the tube in the accurate bronchus. So they are easy to insert and position properly. The anatomy, you need to know the anatomy to the side that you're going. They can be properly positioned during continuous ventilation. So you don't need to stop the ventilation. And sometimes even in the lateral decubitus position, you can actually pass the blocker and get into the desired area. So this thing, there's no need to change the tube when turning from supine to prone position or in postoperative mechanical ventilation, because all you do is pull out the bronchial side and it becomes like a single lumen tube. So you don't need to, usually when a patient is going ventilated into an ICU, you actually take out the double lumen tube and you re-intubate with a single lumen tube. But once you've used a univent, you don't need to change it. All you need to do is pull out the bronchial element and the blocker element, and it just becomes like a normal single lumen tube. So that's an advantage of using this tube. You can selectively block some of the lobes of each lung. As I said, the right upper lobe is very difficult to block. You can go distally and block the bronchus intermedius, not a problem. It is possible to apply CPAP to the non-ventilated operative side. So because it's got a narrow tube, you can apply CPAP and allow some alveolar recruitment on the operating side. So it's important to give you that extra bit of help for your operating side. The other one is called as an aunt bronchial blocker. The thing with this is that it's got a loop at the tip. Can you see the loop at the tip? And what you do is you pass a bronchoscope down the tube and the blocker next to it, and you pass the bronchoscope through the loop. So when you pass the bronchoscope through the loop, you can tighten that loop a little bit, and then you push in the bronchoscope, and the blocker follows the bronchoscope into the side that you desire and into the lobe that you desire. So that's the advantage of an ANS, but it needs a little bit of experience to know how to guide the tube into the side that you want to go. Then you've got something called as Cohen bronchial blockers. The thing with Cohen bronchial blockers is, again, just like the Univent, they have a blocker here. They have a tube they have a blocker within a tube, and the tip is flexible of the tube, so you can actually direct it to the right or direct it to the left. So this flexible tip adds a little bit of benefit while guiding to the left or to the right. And then you've got one more element in the system called a scoop deck bronchial blockers. These can pass through your normal connectors, endotracheal tube connectors, and they can pass in through a normal endotracheal tube, and then you can use it to block the various things. It does have a suction port, but the diameter of the suction port is very small, and usually it's a struggle to actually suck out thick material with these. And then, of course, you've got our local available Fogarty embolization catheters with a 3 ml balloon, or you can use a Foley's type of catheter with a balloon tip. In very small children, you can use a smaller smaller Fogarty's with a 0.5 ml balloon. So you've got one which is 3 ml will be used for the adults. The one with the 0.5 ml will be used for children. Swan-Ganz catheter has a 1 ml balloon that may be used sometimes in a smaller child to get isolation. And these have to be placed with flexible bronchoscopy and sometimes even rigid bronchoscopy to get into the correct area. So these are not easy. You really need to be experienced to be able to put these things. We spoke about it, inability to suction, inability to ventilate. They definitely increase the placement time. You need to be experienced. You might need to use flexible and rigid bronchoscope to get a correct placement. And again, they are not as good as the traditional blockers. So there is a loss of blockage sometimes. And the cuff might actually obstruct the right upper lobe if you're not very careful. This is a special situation where we have designed this technique where while operating on aspergillomas, we found that these aspergillomas seem to have endobronchial communication. And when the patient is awake, he's got enough cough reflex to not allow any endobronchial spillage. But the moment the patient goes under anesthesia, this cough reflex goes away. And unfortunately, the cavity can actually pour itself endobronchially and cause spillage onto the normal side. And then later on in a week or so after the operation, the patient comes back with systemic fungal sepsis of the non-operated side. So we experienced this in a couple of patients, and we thought long and hard, and we tried to figure out what was exactly happening. Why did these patients not so well? And we figured out that this is what was happening. The moment they went under anesthesia, the content of that aspergilloma was spilling and going over onto the opposite side. Since then, we designed this technique. When I say we, I'm talking about our anaesthetist friends who designed this technique, where they would intubate the opposite side and pass a Fogarty into the normal side. So say if you were operating on a right upper lobe aspergilloma, then a double lumen would be passed into the opposite side in a lateral position. So you keep the right side down laterally, and then with lateral intubation, you pass in a double lumen tube into the left side. so that you prevent any spillage. And then you turn the patient supine again, and then you pass in a Fogarty's into the bronchus intermedius. And when you pass it into the bronchus intermedius, you're actually isolating the same side from infection and also the opposite side from infection. The key thing when you're doing this operation is after all this is done, when you come to staple the bronchus, it is absolutely mandatory to ask the anesthetist to pull back the Fogarty. Otherwise, you might accidentally staple it in your stapling line. And so this is important to remember. So I'll just show you how we do that. Sangeeta and Preeti and Sudhir have shown us this technique, and I just want to show you how this technique happens. You need to be a real expert to be able to intubate a patient in a lateral position. A double lumen tube in a lateral position is no walk in the park. But I have to tell you, my anesthetists are A1. And every single time since then, when we have managed to do this, we have actually managed to intubate the patient in a lateral position. And I'll play this video because I want you to see how they are testing for efficiency of isolation. So just watch it for a few minutes. So the anesthetist is now auscultating the chest. He wants to make sure that the tube is well placed. And then they will sequentially clamp off each area. I'll show you in a second. So they have sequentially clamped off. So they have clamped off the tracheal part first, and he's auscultating to make sure that we've got isolation desired. The fact that he's got his right side down means that he's a right upper lobectomy. And so this is a left-sided tube. Once they are sure that they have got the tube in the left side, he will now clamp the left-sided, the endobronchial element, and he wants to see whether he's he's accurately placed or not. And then they will inflate the balloons and then again auscultate to see how well the system is working. So this is how you make sure that you've actually got adequate occlusion. So this is a good video which shows you how exactly the anesthetists work on this thing. So sometimes they will clamp and they will inflate the balloon, deflate the balloon, and readjust the tube. But these guys are really, really good, and they have managed to get excellent position every single time. And this is not an easy technique. To do this with a patient lateral, it really needs a lot of expertise. Okay, so really hats off to these guys. So here they are. Here's the tracheal. I told you the white is tracheal, the blue is bronchial, and then they are sequentially clamping each side to see. When you clamp, you've got to open that side and let all the air out, and then you work on it. Of course, a capnography is also going on, so we know what is happening with the capnography tracing. So they are doing that again, clamping each one sequentially, opening it to air to vent it all out, and then listen to the ventilation on the desired side. Okay. And then once you've done that, you've got to get the patient supine. This is what they're doing. They've got the patient supine. They have now in their hands a Fogarty catheter. I just want to fast forward a little bit. So this is a Fogarty catheter. She's just going to show you inflation of the balloon. So you have to always, before, there's a stillet in the Fogarty's catheter. So you got to get rid of the stillet. You got to take it out. And then you've got to take a syringe with air. You got to decide what is the volume of that cuff. Do not overinflate it, otherwise the cuff gets damaged. And then you inflate it, and you check the Fogarty catheter first before you start introducing it into the chest. And then once you've done this, then you introduce it into the tracheal side, because this tube is in the left. We know the endobronchial element is in the left. So once you pass it into the tracheal side, the only place it can go is the right side. And once it's gone into the right side, you push it as distal as possible, and you want to inflate the balloon to make sure that you have actually obliterated the right bronchus intermedius. And the only way you can confirm this is by putting in a bronchoscope. So they manipulate the tube. Again, the measurements tell you, these measurements are important. They will actually tell you what is the distance that the tube has gone in. And if you have already measured the airway on the CT, you know exactly where the bronchus intermedius lies with relation to the front tooth or the tip of the endobronchial catheter. And then this is Sudhir doing a flexible bronchoscopy while Sangeeta is inflating the endobronchial Fogarty catheter. And this way, we are making sure that the catheter is in the correct place. Okay, so much so about bronchial blockers. Is it clear to everybody? Any issues?
Clear, sir.
Very clear.
Yeah?
Clear, sir.
Okay.
Clear,
then-
sir.
Okay,
Yes.
now let's move on to the next section. Let's look at rigid bronchoscopy, because this is a very complex operation, particularly because you are sharing the airway with the anesthetist. And because you're going to be using energy devices in the airway, including laser, including coagulation and things like that. So it's very important to understand the philosophies in laser bronchoscopy. Let me just mute everybody, okay, and continue. So in a rigid bronchoscopy, I'm going to use Khaled Amer's video. Just listen to it. I'm going to use Khaled Amer's video, a 1.5 minute clip. Beautiful video, probably the best video ever produced for bronchoscopy. And Khaled has given me permission to use it. So here you are. Can you hear, guys? Can you hear this?
No, sir.
No, sir.
No, sir.
Okay, one minute, wait. It's my AirPods that's causing the problem. Okay, just 1 minute, okay? Sorry about that.
The anesthetist usually pre-oxygenates the patient.
Yeah, we
Can you
hear.
hear this?
Yes, yes.
Yes, yes.
The
Yes, sir.
anesthetist usually pre-oxygenates the patient using 100% oxygen for a couple of minutes to give the operator a trouble-free 2 to 3 minutes complete apnea to introduce the rigid bronchoscope. To avoid injury to the patient's teeth, the rigid scope should be resting and fulcruming on the operator's thumb. This is mimicked to the movement of a cue stick when striking the cue ball in snooker or billiard. As soon as the illuminated rigid bronchoscope is introduced behind the tongue, the operator is encouraged to start looking through the scope, keeping the scope dead in the median line. The next step is crucial to entering here, so pay particular attention to it. Lifting up the posterior third of the tongue exposes the epiglottis. Next, the bevel of the rigid scope is introduced for a centimeter or so under the epiglottis, and the latter is lifted up while keeping the scope in the median line. Note that this is a blind move. If the epiglottis is lifted successfully, it will not be seen again. Sometimes the epiglottis is very floppy and difficult to lift up. However, this is a crucial step, and if the epiglottis isn't identified or not lifted up successfully, you should not proceed. Go back one step and try again. To my mind, identifying and lifting the epiglottis is the main cause of failure to introduce the bronchoscope by interns and trainees. Once the epiglottis is lifted and the scope is advanced for a couple of millimeters, the vocal cords should come into view. The operator should make note of the abnormalities of the epiglottis, vocal cords, and the larynx. These should be reported to the ear, nose, and throat surgeons for advice or follow-up, preferably with a photo of the abnormality. Here are some anatomical landmarks to help you describe anomalies to your ENT colleagues. With good muscle relaxation, the cords are seen to be abducted or abducted away from the median line and stationary. The rigid scope is then turned 90 degrees to the right before introducing it via the cords. This maneuver aligns the shortest diameter of the tip of the scope transversely to avoid damage to the cords. Once in the trachea, the Venturi device is connected to the rigid scope to establish ventilation.
So this is the basic principle of doing a rigid bronchoscopy. We do that for removal of foreign body in cases of massive hemoptysis, when we want to do some dilatation procedures of strictures, particularly laser bronchoscopy. It's very, very important. When we want to place stents, when we want to biopsy or stage any malignancy, or establish an airway in a collapse situation. Usually you would use Karl Stoss set. This is my set, which we use in a rigid bronchoscopy. There are various sizes available. You pick up the size depending upon the height and weight of the patient. And then whenever you intubated the stop it.
Kumar.
So after you have intubated, you actually connect the airway to a jet insufflator. It's very important. This is a Venturi high ventilation insufflator. It has got various settings. You can change it to pediatric setting, or you can change it to adult setting, because you don't want to cause barotrauma. So you really have to be careful. You're blowing things under pressure across a rigid bronchoscope. So this is a good technique to be used when you're doing procedures, therapeutic bronchoscopy rather than diagnostic bronchoscopy. The problem, as I said, is you're sharing the airway with the surgeon. That is the most important thing. So there is to be very good communication between the anesthetist and the surgeon. Particularly when you're using laser, you have to tell the anesthetist to switch off the ventilator. And when you say off, you have to say switch off OFF, the ventilation. Because if the anesthetist by mistake blows when you are about to fire a laser, you will cause a blast within the tracheobronchial tree, and that is not good for recovery of the patient. So both have to be highly vigilant, both have to talk to each other. Very often the saturation will drop, so you have to stop what you're doing. You have to tell the anesthetist, please go ahead and ventilate. Give them 3, 4, 5 minutes. When you allow the anesthetist to ventilate for 3, 4, 5 minutes and get FiO to 100% for 3 minutes at least, then you can get a minute and a half to do your procedure. So it's very important to talk to each other. There must be ongoing communication. This is the key to this operation. If you're an anesthetist and you don't get along, don't do rigid bronchoscopy. Certainly don't do laser surgeries with them, because you have to maintain oxygenation and ventilation through the side arm. And they cannot blow while you're doing something. Because one is, of course, the laser problem, and second is when they blow, when they stop blowing, there is fogging. And so when they blow, they sometimes clear your vision to look ahead and move ahead. So it is it's like a dance. It's like a dance between two people, and each one has got to move according to the other person. And of course, there are problems with rigid bronchoscopy. Things like arrhythmias, hypertension, hypoxemia can all happen. Okay, you can do these usually done supine in our setup. Sometimes you can do them sitting. They do use some stuff to dry the mouth, and all monitoring is usual. Sometimes it can be done under sedation and topical spray as you go, but I personally give full general anesthesia and I do it. And usually you use short-acting drugs because you don't want to block off the whole area. You don't want to anesthetize for a long period for a very short procedure. So you have to work out. You don't know how much you will be able to do in that sitting. So always start with short acting. And then if you feel that you need more, then you can always top up your anesthesia. Whenever you're doing rigid bronchoscopy, it's very important to look for postoperative hypoxemia. You need to make sure that the oxygen is supplemented adequately. The sedation has to be light to avoid hypoventilation. And laser precautions are absolutely mandatory. They are really, really, really important. You need to really follow all the precautions for you, for the patient, for the anesthetist, and for all of the staff in the room. It's absolutely mandatory. And I've covered this in my previous lecture. So this is the high frequency jet ventilator that's available. And sometimes you have a Cook's catheter, which can be used to provide jet ventilation across narrow areas. And this is just another device that's available. Okay, so this is about rigid bronchoscopy. Now quickly about thoracic analgesia. What are the techniques available to give intraoperative, postoperative pain relief? Okay, so I personally always put in an extrapleural catheter. This is my standard practice because I do VATS. Anything that I have done for more than an hour, any surgery for more than an hour, I will watch inside and I will put in a extrapleural catheter from the outside. So my camera is inside. I see there the camera is inside. I am looking at the pleura. As I'm going in, I don't want to puncture the pleura. I watch my needle come in and I blow it up with saline to create a space in the extrapleural area. And the moment I've created a space in the extrapleural area, I will put in a catheter into it. And then that catheter will go into the space. And then you inject it with Marcaine and you connect it to a infusion catheter over the next day or two. The beauty of this is that it's not in the epidural space. It is actually in the extrapleural or the paravertebral space. It gives good analgesia to the 3 ports or 1 port that you have made. And patient doesn't have to lie down or be catheterized as is with epidural anesthesia. So epidural actually restricts mobility. So in my practice, I almost never use epidural anesthesia, epidural analgesia, never. I always put in an extrapleural catheter by myself. The other techniques available are cryoprobe. This is a cryoprobe. You can actually block off. So these are selective nerve obliteration during the operation to get relief of pain in the postoperative period. The one thing I forgot to mention in this is I will always inject all my ports with local anesthetic even before I make the incision. So I do what is called as preemptive analgesia. And then once I've finished my surgery, I'll place in an extrapleural catheter and I will also give local infiltration into all my wounds with whatever is left over with the saline. There is something called as an onyx catheter. An onyx catheter is pushed through your through the VATS incision through a tunneler. You've got this device which makes a tunnel in the extrapleural area. You're watching it with the camera, and then you pass in your extrapleural catheter through your port into the thing, or you can pass it through a subcutaneous tunnel and bring it outside on the skin. So this is how it looks. This is the tunnel that you've created from outside through your VATS port, and then you pass your catheter and place it here. You can place more than one catheter at various levels to get high and low level of blockade with these things. Epidural catheters are actually placed in the epidural space, which is next to the spinal cord. This needs a more experienced person. This needs an anesthetist who knows what they're doing, and the anesthetist are very experienced at doing this. And I would put in an epidural catheter whenever I'm making a large thoracotomy or I'm anticipating problems in a patient. But most of my surgery, 98%, is actually done with an extrapleural catheter rather than an epidural catheter. An epidural catheter should always be fixed to the skin, and it should be done before you start doing things. And most importantly, you don't want the catheter coming to the side of the operation. I want the catheter away from my chest. So I will always insist that if I'm operating on the left side, I want the catheter stuck to the right side, because I want to use all of this space. This is my operating space. I don't want any dressings, anything on my side. So always to the opposite side of the spine, I will insist that they place the catheter there. Paravertebral technique is a technique done by the anesthetist. They are going exactly into the same place where you went when you did an extrapleural catheter, but they are actually going into a paravertebral. See this groove? They get into this groove and they inject it. So effectively they are blocking the intercostal nerve as it is coming out. And you have to stay outside the extrathoracic fascia in a paravertebral block. So it's an experience thing. There is guidance that you must use ultrasound. Ultrasound actually helps you to get an accurate idea of where you are going, and it will guide you to put your needle into the correct space. But it does need an experienced anesthetist who can actually help you
to put it into the paravertebral space. So this you do before the operation. Sometimes they do it after the operation to get prolonged pain relief. They can leave a catheter in, or they can give local blocks and come out. But usually once they put in a paravertebral catheter, they'll put in a catheter over it and give continuous infusion for a day or two to get the patient comfortable. There is a technique of thoracic intercostal blocks where you specifically block the nerve at various levels, 2, 3, 4, depending on wherever the patient is got pain. Used sometimes when the patient has got post-surgical pain and he comes into the clinic and he's really not doing well. So this is what you do. You actually mark out with relation to the tip of the scapula, and you draw the ribs, and you got to go on the upper border of the ribs to avoid injury to the ribs, and then get into the intercostal space and then inject the intercostal nerve. So this is a technique which sometimes we do in the outpatient. And we also do this sometimes in theater when we have done a smaller procedure. So if I've done a procedure less than 1 hour and I don't want to leave an extrapleural catheter, I will actually do thoracic intercostal blocks. But because I have got a camera inside the chest, I can see my needle reach that extrapleural space, and the moment they inject, I can see a little bleb forming along the intercostal nerve. So we do this intraoperatively as well. And there is a whole protocol for how you do it and the way you get along with it. And I'm quite happy to share this with you guys if you want it specifically for any particular purpose. Pain relief doesn't just end there. There is other things called as PCA. We do send patients with PCA, which are patient-controlled analgesia. And we keep it for a day or two, at least till the chest drain comes out. The good thing about a PCA is that it locks itself, so patient cannot overdose. So whenever he gets a pain, he can keep clicking on the PCA, but it will lock itself when the patient is trying to overdose. Of course, oral analgesia has a huge role, and you need to do multi-drug therapy. Usually a single drug is not so good. You need multimodality approach for pain control. And I personally, very quickly after my thoracic surgery, convert them into transdermal patch. I'm a great fan of transdermal patch. Usually the oral drugs are, except paracetamol, the others have some side effect or the other. So we give them paracetamol and in the first 24 hours after they have settled down, we give them transdermal patch, usually a fentanyl or buprenorphine patch. And this is put onto the skin, and the patient can even go home with this. Fentanyl, you're not allowed to send the patient home with, but buprenorphine, they can actually go home, and they replace the patch every 72 hours. So there is a continuous slow release across the skin for 24 hours, and the patch lasts for 72 hours. And then usually sometimes the patch can even last for 7 days. Okay, so it depends on what is the effectivity of the patch, what is the dose of the patch and strength of the patch and things like that, and how much pain the patient is experiencing. But minimum is 72 hours. You can change it once the effectivity goes down. So we've spoken so much about anesthesia, we've spoken so much about thoracic surgery, but now we are entering a completely different era. The different era is called as awake thoracic surgery and non-intubated video-assisted thoracoscopic surgery. And this is my friend Jianxing He from Guangzhou, and he has published a textbook on awake thoracic surgery. And really, they are using this extensively for a whole variety of patients. The patient is not intubated. They either give sedation and local blockade, or they give high thoracic epidural. And, they do lobectomies, sleeve lobectomies, tracheal resections, PA reconstruction surgeries, vascular sleeves, you name it, and they're doing it. And he's got more than 1,000+ cases experience with awake thoracic surgery. So China and Taiwan are the two places where this is really gaining in popularity. And they have got excellent results with these things. So you certainly start wondering whether is it really worth doing all these things. And not just awake thoracic surgery, Jianxing has also published a tubeless VATS textbook. This is actually a textbook of tubeless VATS. And tubeless VATS means no central line, no arterial line, no urinary catheter, no endotracheal tube, and no chest drain. You know, he's published a series of more than 700 cases of lobectomies by single port incision and getting into the chest, doing these complex lobectomies and not putting in a chest tube. And they come out, and you know, his need for putting in a chest tube in the recovery is less than 1%. So they just, you know, make sure on table that there is no air leak. They're very aggressive with managing air leaks. And he's got a huge series published where, you know, they really don't use any tubes. And there's a textbook of tubeless VATs. So really things have moved in a big way and people are doing more and more advanced things. Situations are changing and really anesthetists will not become redundant. They will always be needed, but really the boundaries are being pushed. For this, you need a very good anesthetist in table or in theater to make sure that if things go wrong, then you have to intubate the patient. So you need a very experienced anesthetist to be in theater, to give the sedation, to give the high thoracic epidural, or to intubate the patient when things go wrong. So it is not something that the anesthetists are not needed. They are very much needed, but the intervention in the body is going down dramatically. In the UK, we certainly don't do central lines, we don't do arterial lines, we don't do urinary catheters, for sure. But we still do chest drains and endotracheal tubes. So things are changing quite a lot, and you know, we are progressing in a huge way in terms of anesthesia for thoracic surgery. Okay, the time is 7 o'clock. We are 2 hours down the road. I've still got one more talk. I want you to come in and share your experience and tell me if you want me to continue for a little more time, or if you want, I'm very happy to stop.
Continue, sir.
This lecture makes sense.
Yes, sir.
So
We can continue.
Yeah, just let me see what everybody else wants, because it might become too much for them. Hello, anybody's got any?
Continue, sir.
that is a big topic in itself.
Continue, sir.
Continue.
Okay, give me 2 seconds. My heating in the room is too high. I need to switch off my heating. Just 1 minute.
Must continue because it's connected to this.
Okay, let's continue and finish this.
Yeah.
Next part is not that long actually, so it will finish quite fast. Don't worry. Okay, so enhanced recovery after thoracic surgery is quite an important topic. This will come in the exam for sure. We will definitely ask you some questions on this. Either it will come as an MCQ, or it will come in the DNB exam, or it will come in the MCH exam. For sure, ERAS is always discussed. Even in Vivas, we discuss ERAS. So ERAS actually started with the concept that surgery is physiologically morbid. There are homeostasis disturbances. There is a stress response. There is a catabolic response in the body. And overall, there is an increased oxygen demand for the body. The colorectal surgeons are the ones who first look at all these metabolic response to trauma. And they said, if you could standardize the perioperative care and made sure that every patient was fit for surgery and patient had a good optimal level of treatment pre-op, intra-op, and post-op, then the patient's journey will become smoother all the way from referral to the surgeon to discharge. So this is a whole, ERAS is a philosophy of taking care of a patient from the point that he's referred to you all the way to the point that he's discharged. So it's not just a one-off, get rid of the patient early philosophy. It is continuous therapy over a period of time. The ESTS and ERAS Society got together and they actually adopted this for thoracic surgery. So ERAS in thoracic surgery is a guideline. It comes from the guidelines. Okay, it comes from the guide, and everything I say is going to be there, is part of the guideline. So this you can blindly answer in your exam, okay, when these questions come. So every slide is helpful for the students. We have got the ERAS protocol now established at BARTS, and we do quite a lot. So the evidence on which ERAS is based is a grade system, high quality, moderate, low, or very low quality. And of course, the strength of recommendation is strong or weak, okay? So whenever I talk about any of the recommendations, I will mention this grade of recommendation. So let's look at the various factors that are important. So pre-admission information, pre-admission education and counseling. What does ERAS say? It says it is highly beneficial, highly recommended. Pain control is definitely better when the patient is psychologically and mentally prepared for the surgery, and the level of recommendation is very strong. So if somebody asks you, should you give handouts and things like that? This is a study of multiple papers, okay? This is meta-analysis, and these are the outcomes that I'm telling you. So definitely pre-admission information, education, and counseling, highly recommended, should be done. What about, these are the sort of things that you must give out to the patient. You must use these pain scores, visual analog pain scores, which will help the patient and which will help the doctor understand what is the pain level of the patient. What about perioperative nutrition? What is the importance in ERAS of perioperative nutrition? Preoperative fluids should be given. Actually, patients should not be fasted for a long period of time. They say only minimum of 6 hours. In fact, you can go down to even 2 hours of clear fluids, okay? So no longer is this concept that overnight he's fasted and then he gets operated at 4 p.m. Next evening. That is not actually gives you good outcome. They have very strongly said that you must avoid fasting to as low number as possible. Perioperative fluids can be given to the patient to keep him hydrated. This is not abdominal surgery, it's thoracic surgery. Within 4 hours, the patient must be back on diet. This is a recommendation of ERAS, that you start early oral feeds and stop all IV things. Very, very, very important. And not only early oral diets, but you must give oral nutritional supplements. This is part of ERAS protocol, and you must do these things. Screening for nutritional status is highly spoken about, and preoperatively you must correct any nutritional deficiencies that the patient has had. Oral nutrition supplements like Protein X and other stuff are recommended for malnourished patients before they undergo thoracic surgery. There is very little evidence for immune enhancing nutrition. These are some specific sort of diets which talk about improving outcomes, but these ones are only recommended for post-operative, not in preoperative. In preoperative malnourished patient, it is the nutritional supplement rather than the immune enhancing nutrition that should be used. Smoking cessation, highly recommended, increases risk of morbidity, and we know that preoperative smoking cessation, at least 4 weeks before the operation, is the recommendation that comes from ERAS. So in the exam, if they ask you how many days should this patient stop smoking, at least 24 hours before, but ideal is 4 weeks. That is what ERAS says, okay? Alcohol dependency increases perioperative morbidity and mortality. Lung cancer surgery, they have specifically looked at it. There are many papers. We know that alcohol dependency increases pulmonary complications and decreases survival. So preoperative alcohol cessation is strongly recommended by ERAS. This is from the ESTS guideline, okay? So you must insist on this. At least 4 weeks abstinence is spoken of, but of course, you have to support the patient through the abstinence with other medical therapy or whatever else is available. Anemia management, this is very important. Very often in the exam, you're asked in the long case or short case with an HB of 7 or 8. So it's important. Correction of preoperative anemia is strongly recommended. This is part of the ERAS guidelines. Iron therapy is the recommendation, okay? Iron therapy is a recommendation. Preoperative transfusion and erythropoiesis stimulating agents are not recommended. Do not think that you can correct anemia by giving blood transfusion. It is iron therapy that is the recommendation of ERA's guidelines. Okay. What about pulmonary rehabilitation and prehabilitation? Again, we know it directly reduces length of stay and pulmonary complications, and particularly for patients with borderline lung function or exercise capacity, strongly recommended. So it is mandatory part of an ERA's guidelines that these patients do well when they are given at least 4 to 6 weeks of preoperative rehabilitation. And I showed you this last time. In my personal practice, we do yoga and things like that. In your practice, you can do whatever you like. You can use physiotherapy, nebulization, incentive spirometry, whatever you want, but you must do prehabilitation of these patients. Perioperative fasting and carbohydrate management. You do not need to fast the patient for a long period of time. Clear fluids can be allowed up to 2 hours before surgery. Okay, solid fluids have to be stopped, but sips of fluid can be taken almost up to 2 hours before surgery. Solid fluids at least 6 hours, but clear fluids only 2 hours before surgery. Oral carbohydrate routine is actually recommended by the ERAS thing. It says that if you load them with oral carbohydrate, they actually handle the metabolic stress of surgery much better. But not in diabetics. In diabetics, you cannot follow the oral carbohydrate loading. Okay, so this is straight out of the ERA's guidelines. The fasting guidelines are very strong. Recommendations are based on very good evidence, level 1 evidence. So you must follow these guidelines. And the carbohydrate loading is also strong, but based on extrapolated data from meta-analysis of all the papers that have been published. So these fasting guidelines, if your anesthetist next time gives you trouble, you throw the ERA's ESTS guidelines on their face. They cannot actually do without the ESTS guidelines. Okay, these are important guidelines and they are based on evidence. What about pre-anesthetic medications? Avoidance of sedatives. They say you should not give sedatives preoperative. Melatonin, relaxation technique, and music therapy are the ones that are spoken of in the ERA's guidelines. So you can use any of these for calming the patient down, but not sedatives. DVT thromboprophylaxis, again, mechanical and pharmacological DVT prophylaxis is strongly recommended. The level of evidence is strong according to grade. Extended pharmacological therapy is only in high-risk patients. But again, the evidence is not, we don't have enough evidence to show that a long-term DVT prophylaxis for 3 months or 6 months has benefit in high-risk patients. But if it has to be used, you have to only use in high-risk patients. And what they recommended is low molecular weight heparin for 4 weeks, particularly in the high-risk patients. Antibiotic prophylaxis and skin preparation. Antibiotic prophylaxis is a strong recommendation. IV antibiotics should be given 60 minutes prior to incision because you need to reach peak plasma level at the time of the incision, not 10 minutes before. It has to be given 60 minutes before. And hair clipping is the only, you should not shave the patient a day before or on the morning. Shaving is not recommended. We actually shave on the table, not shave, we clip the hair. We use a clipper. We don't use a blade or a knife or anything like that. We use a clipper. So hair clipping is only if required, okay? And then this is strong recommendation according to the grade. So don't shave, it causes infections. They are not recommended. The night before to make the patient like a plucked chicken is not part of ERA's guidelines. Okay, and if you have to do skin preparation, use chlorhexidine alcohol rather than povidone iodine. Okay, this is all the studies that have looked at the two. So chlorhexidine is the recommended agent for skin preparation rather than povidone iodine. What about intraoperative hypothermia? There's a strong evidence to use active warming device. Okay, so grade recommendation strong is very important to understand this. And continuous measurement of core temperature for efficacy and compliance is indicated, strongly indicated, okay? Anesthetic protocols, a double lumen tube, bronchial blockers in specific cases. Fiber optic bronchoscopy is part of the protocol. It is recommended that you use fiber optic bronchoscopy to place a double lumen tube, okay? Lung isolation, but tidal volume should be kept low, very important. and the PEEP can be reached at optimum levels. Don't over PEEP the patient. And non-intubated anesthesia is still not clear whether it has any benefits in an ERAS protocol. So non-intubated anesthesia does not feature as a part of an ERAS protocol. But hopefully with time, more evidence will come in, more randomized control studies will come in, and this might then feature in the ERAS. At the moment, we do not have enough studies to support non-intubated anesthesia as a ERAS protocol. Lung protection strategies should be followed during one lung ventilation. Non-intubated thoracic surgery, I told you about that. Awake thoracic surgery, not yet. We don't have the evidence. Everything that I spoke before are studies which have looked at, can we do it? So we know that they can do it. We know that it is possible, but they have not done randomized controlled trials versus ventilated patients to know that non-intubated thoracic surgery is better than intubated surgery. Hence, it is not recommended. So at this moment of time, we do not have enough evidence. The grade level does not allow us to recommend it as a guideline. A combined regional and general anesthesia is strongly recommended. There's a strong recommendation for extrapleural, epidural, whatever you want to use, you must use regional analgesia for these patients, okay? And if you're going to use any anesthetist, short acting is what is needed, or intravenous anesthetics are needed. So any combination of short acting or IV anesthetic is recommended strongly by the ERAS protocol. Postoperative nausea and vomiting control, use of non-pharmacological agents is recommended, okay? Carbohydrate loading is included, avoidance of fasting is included, avoidance of dehydration of the patient, and multimodality pharmacological need if the patient requires. Then don't use a single drug, use more than one drug. So first choice should be non-pharmacological, and if the patient is not settling or he's got severe problem, then use multimodal therapy rather than one drug itself. So it reduces the opiate consumption. The key thing is reduce opiate consumption in these patients, and that will give you good outcomes in the postoperative period. Regional anesthesia and pain relief, I told you preemptive analgesia, intraoperative analgesia, paravertebral block, post-op multimodality analgesia, ketamine in patients with chronic pain, and dexamethasone. These are all the recommendations of the ERAS guidelines from ESTS and ERAS Society. So all of these can be used. The level of evidence is strong for all of these, okay? Euvolemic, the fluid management should not be hypervolemic. You should be euvolemic. You must use balanced crystalloids. That is mandatory for good outcomes. Do not drown the lungs. That gives you postoperative pulmonary edema, not good. Early enteral feeding is indicated, strongly indicated, okay? So these are all strong according to the grade recommendations. So do not, underestimate the value of these points. They will give you good outcomes in patients. Do not start IV fluids. That is the worst thing you can do for patients, okay? AF prevention, they've spoken, they've said avoid beta blocker withdrawals, replace magnesium, and diltiazem and amiodarone with prophylaxis in high-risk patient is there, but weak evidence for that. So we don't have enough data whether diltiazem and amiodarone can be used as a prophylaxis. You can use it as a therapy, but to use it as a prophylaxis is not indicated. Do not stop beta blockers. That is important, okay? Do not stop beta blockers. Give it even on the morning of the surgery. Thoracotomy, if you have to do a thoracotomy, then muscle sparing. Intercostal muscle flap reduces pain. Nerve sparing techniques are mandatory. Avoidance of nerve compression while reapproximating ribs are all part of the thoracotomy world, which you should follow when you want to do ERAS in these patients. VATS for early lung cancers is recommended. There's a strong relation of VATS outcome in early lung cancer. It's probably one of the first recommendations for VATS that has come out from this. More so when the patient has got poor lung reserve. I have also published a paper for guidelines on optimal management of lung cancer. In that as well, VATS has actually come out as a recommendation for early stage lung cancer. A number of port makes no difference whatsoever. Every evidence has been looked at, and number of ports makes no difference. The uniportal guys are jumping up and down, but at the moment there is no evidence to show that single port is better than multi-port. The same finding came out in our paper when we did optimal management guidelines. And I'll do that one of these days with you. I was one of the authors of that paper. And so uniportal has no benefit over multi-port at the moment. Routine use of robotics, there is no evidence as yet. There is absolutely no evidence that you should use robotics routinely if you go by guidelines, okay? Chest drain management, number of tubes, suction versus no suction, digital drainage, pleural fluid drainage, all of this has been looked into. And really the data is very ambiguous at the moment. The only thing we can say is if you have to use tubes, use a single drain. Suction versus no suction has no recommendation. It depends on whoever is the thing. But if you do use suction, you have to use digital suction. That is the recommendation. And the amount of pleural fluid that is draining out, at what point you take the tube out, this less than 100, less than 50, has no recommendation whatsoever. So there is no science behind waiting for 5 days with a chest drain, waiting for the fluid amount to come down to 100. You can take out the chest drain without hesitation, okay? Single chest tube strong, avoidance of external use of routine suction is strong, but if you do use, you have to use digital drainage, okay? So suction versus no suction is an issue. High pleural output is acceptable. 450 ml for 24 hours is the figure now. Some papers have gone up to 600 ml, but there is no randomized control on that. So at the moment, looking at all the papers, even 450 ml per hour is not an issue, okay? It's not an issue to take out the chest drain. So this is the digital suction device that we use. For me, Topaz is the one. Routine use of urinary catheter is not required. Completely clear about this. You should not use urinary catheters. Thoracic epidural is not required at all. Not recommended as part of the ERAS guidelines. Only when patient goes into postoperative retention is when you use a urinary catheter. So it is not part of routine thoracic surgery. Early mobilization and adjuncts to physiotherapy. Early mobilization is strong. You must actually mobilize the patient within 4 hours of the operation. What is this MT? I don't know. I forget. Incentive spirometry is a query. I told you they're not clear about incentive spirometry, and routine use of NIPPV is not recommended. Okay. So you should not use non-invasive ventilation routinely. Incentive spirometry, I showed you a paper yesterday where they've done a beautiful randomized controlled trial, and they've said that it actually adds very little value to the outcomes of these patients. They've looked at cost benefits of ERAS implementation therapy, and in Medanta, it's a very good tool. We have used ERAS quite extensively. Even in BARTS, we have used ERAS quite extensively. So I am a great proponent of ERAS. But this is a slide from Alan Seho. If you think that just uniportal VATS is making a difference to the patient, then you are mistaken. It is not VATS. It is a combination of physiotherapy, communication, mobilization, wound care protocol, investigating algorithm, air leak management, chest drain documentation, and analgesia strategies. All of it come together, and that is what gives you good outcomes in ERAS. So it is started from colorectal, but now being used in thoracic surgery. And really, it gives you best clinical outcomes for patients if you follow these guidelines. They are in black and white. There is no confusion about this anymore. Okay, thank you very much. Oh. Sorry.
Sir, one question.
1 minute, wait, 1 minute. Don't be so excited. Just wait. Just wait 1 minute. Give me a breathing space. Okay.
Yeah.
Okay. All right. So what's the time now? Time is 7:25. Okay. I rushed to ERAS because it's been very long, but they are very clear cut, written in gold. Okay, black and white. You don't have to worry about it. Anybody asks you questions on these, you just say, this is there in the paper. And this is straight out of the paper, meta-analysis and all papers looked at. The committee has done a very good job. And I am very happy for them to be sort of accepted in the exam. Okay, now I'll take questions. I'm going to start recording.
So roll of,
who is it? First,
So
identify yourself and then ask the question.
So Bhushan here.
Yeah, Bhushan.
Yes, sir. Role of thromboprophylaxis or postoperative DVT prophylaxis for in ERAS, basically.
Strongly recommended. Heparin is the one. And on table, you have to use DVT pump. It's mandatory. The DVT pump and then use these TED stockings.
Okay, okay.
You can discharge the patient home in 24 hours with TED stockings. And within 6 hours of surgery, if the patient is not bleeding and if things are okay, you can give 1 shot of heparin, Clexane.
Clexane, okay.
Clexane is the one that, low molecular weight heparin is the one that's recommended.
Okay.
Okay, but not a prolonged period. No, single shot is enough. But DVT, TED stockings and intraoperative, you have to use the DVT pumps. That is mandatory part of ERAS. Okay, next question.
Hello. Thank you, sir, for your talk. My question is on...
Who is it first? You have to
Kevin.
Can't see everybody.
Okay, my name is Dr. Kevin. I'm from Kenya. I was listening to your talk.
Hi, Dr. Kevin.
Yeah, I was saying, in terms of analgesia, I didn't hear you mention about the erector spinae block in terms of analgesia in thoracic surgery. What's your experience with it?
I have no experience with erector spinae. Is it the same? Is it the same like paravertebral block?
Yes, sir. It is kind of same like paravertebral block. Our anesthetists are using it frequently for CABGs.
It's not part of any guideline or it's not
No, they are using for CABG and it is good, very good, sir.
Okay, I have no experience with erector spinae block because I live in an extrapleural catheter.
Okay, thank you.
Thanks. Next.
Hello, sir. So Shilpa on the side.
Yes, Shilpa.
How do you then actually manage newly detected post-op AF?
That is a standard protocol, isn't it, Shilpa? You have to use medical pharmacological therapy for that, and then
beta blockers,
beta blockers and whatever.
Amidorol.
That's the standard. Whatever is
okay.
Protocol. That's not part of ERAS.
Okay.
Hello, sir.
If you get AF, then you just give the therapy that you need.
Hello.
There's all guidelines for AF actually. If you look in the American College of Surgeons guidelines, there is a whole therapy for AF, what you do in case of AF. It usually starts with amiodarone loading 300 as a load. You need a central line. You cannot give it peripherally. 300 loading dose and 900 over the remaining 23 hours. So 300 over 1 hour, 900 over 23 hours, and then continue it for 3 days, and then convert to oral, and then continue for 3 months. That's amiodarone. Then you can use delta as a. There's a whole. It's a whole gamut of management. Different people use different things, but the guidelines are covering that.
Hello.
Digoxin.
Yeah, digoxin, whatever you want.
Hello.
That is, there's a whole different management for that.
Hello.
Yeah. Who is that? You have to identify who's talking.
Amir.
Amit from?
Amir from India, sir. Vellore, CMC Vellore.
Okay, Amir, tell me.
So I want to know what is your preoperative hemoglobin cutoff level, and if it is low, then how do you manage?
We usually, in the UK, blood transfusion is not part of any preoperative workup. It's not part of any preoperative workup. You should not give blood transfusion. There's a direct correlation in bad outcomes in people who have received transfusion pre or peri-op. Okay, so we actually do not give blood. For me, the cutoff for hemoglobin is 7. Anything less than 7 is a real problem. That's where I will think of transfusion. But if it's not an emergency surgery, it's a purely elective surgery, then you have to give iron therapy. That is the recommendation. Across the world, almost everybody does iron therapy. Or you treat the underlying cause. Okay, but blood transfusion cutoff is 7, not higher than that. Anything higher than that, I will just treat electively, not as an emergency. And blood transfusion is not the answer. The reason why I say this is because you got to remember blood transfusion is an organ donation.
Yes, sir.
Would you lightly give somebody a liver? Would you lightly give somebody a lung? Then why would you give somebody blood? Let's just stop it up. This concept of let's just stop it up has to stop, because it is an organ transplant from another patient. You're putting it into your body. There is enough literature to say that it is not good. It affects the immune system and it affects postoperative outcomes, particularly in thoracic surgery.
Okay, thank you, sir.
Thanks. Next.
Hello.
Yeah, hi. Who's that?
Hi, I am Dr. Vaikar from Sri Lanka.
Hi, Dr. Vaikar.
Hi. What are the ways to avoid hypoxemia during one lung anesthesia, especially during thoracic aneurysm surgery, where both lungs are normal in a normal way? Because hypoxia is less common in destructed lung. But if the lungs are normal, then hypoxemia is very, very pronounced. So what are the ways you can avoid this hypoxemia in those patients? For example, aortic arch surgery, where you need a one lung anesthesia.
Yeah. So the philosophy of ventilation is high oxygenation and clearing of CO2. This is the bottom line. Okay. So whatever you want to do, you have to make sure that the ventilation is up to a maximum level and there is no collapse or atelectasis of the lungs. So you recruit as much alveoli as possible. Hence you maintain a PEEP. There is a PEEP that you have to give. And again, you have to maintain a good tidal volume on the normal side to be able to get adequate oxygenation. So FiO2 of 100% is needed during the operation. So we have two philosophies: oxygenate the patient and maintain the respiratory rate in such a way that you're clearing the CO2. If you can maintain these two, no matter what surgery you're doing, you will be able to correct any hypoxemia that happens on table. Many a times you have to stop your two-lung ventilation, your single lung ventilation, and you have to go on two lungs and allow the anesthetist to oxygenate on two lungs. And then the oxygen comes up and then go on single lung. So you have to stop and start your surgery. Particularly in thoracic surgery, many times I have to stop and start surgery. Surgeons are very reluctant to stop their surgery. But really, outcomes are not good with hypoxemia. The last thing you want is neurological complications and things like that. So whenever my anesthetist tells me I want to reinflate the lung, I will stop my operation. I will step back, let them do whatever they want to, and then go back on single lung, and that will allow you to continue your operation. So that is the philosophy of management of hypoxemia in one lung ventilation.
If you add some CPAP to the non-ventilated lung.
Adding of CPAP, adding of PEEP, all of this helps.
To the non-ventilated lung, I'm asking.
Yeah, all
that
of this
can help.
Yeah, it helps. All of these help.
Can I
adding
ask you one
PEEP
more?
Adding of PEEP helps, but surgeons don't like it when they are operating on one side. And when the anesthetist is giving PEEP to that side, they don't like it because the lung starts to expand slowly and it comes in your way. So very often you are actually resistant to PEEP and CPAP, but you have to realize the anesthetist is responsible for the oxygenation of the patient. And if he needs it, so be it. I don't have a problem if they add PEEP to one side. And mind you, I do all my operations with VATS. So I've got a camera in there, but even though there's a camera in there, I don't mind if the anesthetist wants to give PEEP or CPAP. Unless they're blowing up the lung, that is different.
Is it possible to ask one more question? In your talk, you did mention about the insufflation of carbon dioxide in pediatric patients during surgery. Can you explain to us? I mean, I was not very sure about it.
Yeah, so, see, when I'm doing a very small child and I'm doing a mediastinal surgery, say I'm doing a thymectomy, then in that situation, they may not have a small enough tube to get isolation of the side that you're operating. Okay.
Yes.
But for me, I am not operating on the lung. I'm operating on the mediastinum. So I put in my ports. They are all locked ports, and then I gently introduce CO2 into the chest that I am operating on. And what happens is the CO2 pushes the lung down enough for you to put in the camera and you to put in the two instruments, and then the CO2 also dissects ahead of you, particularly when you're doing thymus or you're doing a small mass or something like that, or a thoracic cystic hygroma. These are the sort of surgeries in kids where I am quite happy to use CO2. But when I'm doing a lobectomy, I really want the lung to be isolated. I want it collapsed. But when I'm operating on the mediastinum, CO2 helps you to push the lung away enough to get access to the mediastinum.
Thank you very much, sir.
Pleasure. I hope this lecture was of use.
Yeah, fantastic. It was very nice. Very nice. Excellent.
Somebody from Sri Lanka. Excellent.
Yeah, I'm actually from India, but now I'm working in Sri Lanka.
Excellent. Good to see somebody from Sri Lanka.
I'm cardiac anaesthetist.
Excellent. Excellent, sir.
Thank you.
Oh,
Nice
anesthetic. Oh, I'm
yes.
now good. Okay. Next.
Yeah, it was very nice. Yes.
Hi, sir. Hi, sir. Shubham here, sir. Shubham from Delhi.
Hi, Shubham. Shubham Garg.
Yes, sir.
Hi, Shubham.
Hi, sir. So I just wanted to ask about the tracheal width that you mentioned, deciding the size of the DLT that we want to place. So is there a particular, anatomical landmark where we want to measure the tracheal width, or, we can take it anywhere? Because that's a real challenge. Many times, at least in our setup, the anesthetist sometimes, put one tube, then they put another tube. They're not very sure. So
it's more than the tracheal width. What gives you a good clue is the height, weight of the patient. Okay. It is actually the height of the patient that's a very good indicator. So if you follow the formula of height of the patient, then that's good. If you're going to use tracheal width, then look at the narrowest diameter of the trachea, which is in the glottis. Okay, because that is the part where it is most difficult to go across. So it is the narrowest diameter of the trachea what you have to follow, or you have to follow the height of the patient. That is a good indicator. Okay. The problem is if you take a very thick and trachea was very wide, okay, 2.5 centimeters, but the glottis was narrow. No point taking a 41. Do you understand? So it is actually the narrowest part of the trachea that should guide you. And always speak to your radiologist. They have the 3D software, they can recreate it. And actually, in my setup, I go down to Tarun sometimes and he will tell you exactly what is the size of double lumen tube that will go in there. Okay. It's actually easy. It's the narrowest width of the trachea that you have to take. And that can differ from patient to patient.
Okay. Thank you. Thank you.
Thanks. Next question, please. No more? Everybody happy?
I have a question, sir.
Yeah, who's that?
Khalil, this is Jibril Khalil, sir.
Yeah, Jibril.
Yeah, my question is about post-operative pain syndrome and the management on that is thoracic anesthesia. What do you use? Is it just oral drugs after thoracotomies? And then how often?
I have multimodality management for this.
Okay.
First is, of course, your pharmacological management. So you can give all these anti-inflammatories, etc., etc. You can then give Lyrica, which is a nerve stimulating agent, 75 milligrams a night. But once they follow up with me in the outpatient, particularly the VATS patient, and they have chronic pain in the chest, then I refer them to my yoga therapist, to my integrative medicine therapist. And they have these special oil wells that they prepare, and they treat these wounds with heat and oil fermentation and Ayurveda. And that has worked a lot in my group of patients. The other thing is, if they're still not settled down, then I speak to I have a pain management specialist anesthetist, and my pain management anesthetist actually can do intercostal blocks. He can do either a long-acting anesthetic block, or he can do a neurolytic, something that destroys the nerve. So they phenol injections and all that. So, or they also do RFA ablation of that nerve. The problem with all of these techniques is that you end up with a anesthetic patch across the intercostal space. Somebody's phone is making a funny noise. Switch it off here. What's wrong with this? So there's some noise in the background, guys. So that is there are multimodalities. These are a very difficult group of patients. 1% of patients will end up with this. Now with the use of integrative medicine, Ayurveda and all, my group has gone down dramatically. And really over the last 8-10 years, I have found that these guys treat them really well, and I'm quite happy with the outcome. You must read my paper on Ayurveda, what was it? Ayurveda and robotic surgery. It's a very nice paper where we talk in detail about all these treatment protocols. It was published in JTD.
Okay.
Look, I can't remember the name, exact name, but type my name and I'm the first author.
Okay.
Okay, next question.
Sorry, a question again. How often?
There are some more questions coming from here. Let me just try and answer some. Okay, 1 minute. So why not internal intercostal block instead of external? Yeah, you can do internal intercostal blocks. You can. When you're in there by VATS, you can put in a long needle across and inject all of things. The problem is finding a needle long enough, because I do 3 ports. I come from the one port is anterior, and then you put in a long needle. Very often you don't get this long needle to reach all the way to the back. So that's why we inject from the skin outside. But you can inject from inside. You can use a long needle, identify the various intercostal neurovascular bundles and inject them a few levels. And you need to make sure that you cover all of the ports that you're using for surgery. So you can go internally as well. What is that? Is there any role of recruitment and de-recruitment? I am thoracic surgery, increasing minute ventilation better than increasing. All of these are anesthetic questions, man. You can ask your anesthetist about all these things, minute ventilation and all that. I'm not the right guy to tell you these things. All of these manipulations can be done. There are available on the ventilator is another completely great device. If you don't want to use PEEP, you can increase, decrease the respiratory rate. You can change the minute ventilatory rate. All those things are possible. But I'm not an anesthetist, so I don't know much detail about how they do it. But all of that is possible. Yeah. But the commonest thing is PEEP. Most of us use PEEP for recruitment. Some anesthetists say you can put any sided DLT no matter what. Just agree. Now the answer to this is yes. You can put any sided double lumen tube and you can operate no matter what. But in my practice, if I am going to be doing a lobectomy, okay, if I'm doing a wedge resection in the periphery, it doesn't matter. Left-sided DLT is good enough. I'm very happy to operate. But when I'm doing a lobectomy, I am manipulating the main bronchus. I'm lifting up the lung. I'm pulling the lung up, down. I do not want an double lumen tube on the side of the operation. When I do my, I'll show you someday, I have had cases where the double lumen tube accidentally came on the side that I was operating. I was doing a right upper or lower lobectomy, and by mistake, the tube came on the right side. And when I lifted the lung up, the tube punctured through the membranous part of the trachea. So I never, ever, ever want a double lumen tube on the side that I'm operating, particularly when I'm doing a lobectomy, segmentectomy, and stuff like that. If you're doing a wedge resection on the periphery, or if you're doing a pleural surgery, it doesn't really matter. You can put a left-sided and you can isolate whichever one. But if you're doing advanced surgery, like we are doing, pneumonectomies, lobectomies, sleeve resections, and particularly by VATS, you do not want the tube on the same side. Absolutely not. So if I'm operating on the left side, I will insist that the tube goes to the opposite side. I don't care if there is no experienced anesthetist to put in a double right-sided tube. Then I shouldn't be operating. But I insist that you should put the tube on the other side. So it depends on that. Okay. All right. What next? Yeah, Jibril, come in with your question.
My question was still about the post-thoracotomy pain syndrome. Is it common with VATS surgery also?
Yeah, it's not common at all. It's not common. It's not common, but it does happen. It depends on the experience of the operator. You've got to remember, When you are operating through a probe, your instruments are actually rested on the ribs. And it depends on where you made your incision. If you have made your incision on the top of the rib, it's okay. But very often you find the incisions are placed in such a way that your instrument is hitting the intercostal nerve. So it can happen, yeah. But much less with that. Much more with
Okay.
okay. Thanks.
Thank
Any
you.
other questions, guys? Anybody else happy? Everybody happy?
Sir, Amol here, sir.
Yeah, Amol, tell me.
Sir, this is regarding tracheal stenosis.
Yeah, go on.
Yeah, sir, sometimes for non-thoracic cases, patient present with tracheal stenosis who are usually asymptomatic in their history. So how to go about the intubation and prevention of injury to this stenosed trachea, sir?
Why would somebody have a stenosed trachea? It's not routine to have a stenosed trachea.
Sir, in our CABG cases and all, we usually and on X-ray, and when we are seeing the X-rays, there is a stenotic segment, and even the anesthetist, while intubating, they see a small segment, maybe some infection related or injury related, sir.
Then you have awake fiber optic intubation. If you're worried about tracheal injury and things like that, you have to pass a guide wire, and you
Yes,
have to intubate on top of the guide wire. That's why there is something called a Cook's catheter. Okay, I mean, we are not talking about a tight stenosis, isn't it? We are talking about a
yes, sir. Yes, sir.
But the fact that he is not symptomatic, then it just means that you have to reduce the size of the endotracheal tube. Now, the important thing to remember, as I told Shubham, is you don't measure the size of the largest diameter of the trachea. You measure the size of the lowest diameter of the trachea, wherever is the stenosis. The problem is it's not noticed until and unless the patient lands up on table. That's the problem.
Yes,
If you have
yes, sir.
preoperatively, you will go down to the anesthetist, you'll go down to the radiologist and recreate whatever you want to do.
Yes, sir.
Problem is they don't see the chest X-ray till he comes on the table, and then you are suddenly struggling. So the answer to that is either awake fiber optic intubation, or you use a guide wire and pass in a tube over the guide wire.
Yes,
But
sir.
usually a single lumen tube is not difficult to pass over whatever is the. If the patient is not symptomatic, you're okay. You will be able
Yes,
to
sir.
pass a smaller size single lumen tube.
Yes, sir. And sir, during lobectomies and all, this collateral ventilation, how much it is significant, sir? Is it really significant?
Yeah, the collateral ventilation is a problem when it's on the same side, isn't it? The
Yes,
collateral ventilation causes a problem when you are talking about the same side. But when the tube is on the opposite side and you're ventilating the opposite side, collateral ventilation doesn't come into picture.
Yes, sir. Yes.
Do you
Thank
understand?
you, yes, sir. Yes, sir. I understand.
You're in the right or the left main bronchus.
Yes, sir. Anyway, we have.
Yeah,
Yes,
it
sir.
doesn't
We have
matter.
knocked out the whole lung. We have knocked out. Okay, sir.
The whole lung is knocked out. So collateral will not come into picture.
Okay, sir. Thank you. Thank you, sir.
Okay. Somebody is asking me, how is a digital drain advantageous over a PleuraVac drain? This is a whole different conversation. You have to use a digital drain. You have to read the literature. Alexander Brunelli's papers on digital drain, and I think it's a great technology. The reason why digital drain is better than any other drain is because it gives you a consistent suction. If it gives you a wall suction, if it says 2, it may not mean 2. You really have to adjust the knob very clearly. Whereas in a digital, if you put it at 2, it really delivers 2. So that's number one. Number two is that digital suction allows you to make the patient mobile, because he's not stuck to the bed and to the wall suction. You just take everything off and give the little device in the hand of the patient, and the patient can walk away. So very clearly, the mobility is improved with digital suction device. Number three is you have a graphic representation of the number of the air leak. So you know that, 1500 dropping to 700, dropping to 100, dropping to 30. There is a graph which actually shows you, and the actual number comes in. In a PleuraVac, you have to look at bubbles and things like that. So that's not a more accurate representation. So there are many factors where digital suction outplays the normal suction device or a PleuraVac device. So nowadays, if you can afford it, and if you've got a setup where you have access to digital suction, you must use it. Very good outcomes with digital suction, unless you are a believer of no suction. If you believe in the no suction philosophy, then it doesn't matter. Okay, any other questions? Which stapler do you prefer, Covidian or Ethicon? That's not a valid question. I use both. I use both different staplers for different situations, and it's not part of this discussion actually. Staplers I use Covidian, I use Ethicon. When we do lobectomy talks, you can ask me that question. If you go onto the Thoracic Guru's YouTube channel, there is a lecture there which talks about how to use a stapler. And you can use anything, whatever is your preference, it doesn't matter. I use all types of staplers. I have very specific indications in what situation I use what, and that comes with experience. Each one of them has benefits, each one of them has disadvantages. And so you have to optimize your benefit and disadvantages for this, for the patient. Today's talk is not about lobectomy, so let's not talk about that. Okay, next question. Anybody else? Okay, thank you very much, guys. It's been fun. I enjoyed doing this talk. It's good to know that there were anesthetists on this lecture. They were listening. And, I'm pretty certain they must have a few comments to make. But I don't think anybody can cover this topic in so much depth, at least not for surgeons. I'm pretty certain the anesthetic resident would have learned a lot as well if he came on this thing. Thank you very much, guys. Anything else?
Thank you, sir.
Social things? I've stopped recording, so you can say what you have.
Thank you very much, sir.
Thank you, sir.
So we had a full house today, and we had a lot of YouTube as well. I think. I don't know what is on YouTube. I'll have a look later. We've been having regular hits of about 350 to 400 people. Not bad, huh? Tomorrow is Khalid. Tomorrow is who? Khalid?
Dr. Khalid.
N2.
Yes. N2 disease.
N2 disease.
N2 diseases. My mentor, my guru, and everything I am today is because of Khalid. So it really will be an honor to host very close family friend. I go to him for all sorts of advice. He always guides. Okay, thank you very much. Bye bye. See you.
Thank you, sir.
Okay. Thank you, sir.